Committee Room 29, signed. 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 Committee Room 29. Sound. 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 Committee Room 29.
2 online and 4 of us here. Just to welcome everyone to today's meeting. Today we have 2 oral briefings. The committee will hear from the Department on Dental Services. You know that this is a briefing that we had to reschedule from June. And we also have the Reimagine Children's Collective on the review of children's social care services. The committee will also consider a statutory rule on a draft statutory instrument and 2 written briefings from the department, just to declare the meeting open to the public. And the meeting will be recorded and broadcast through Parliament buildings and online. And just to advise members and anyone in the public gallery that you're welcome to use your mobiles as long as they're on airplane mode and muted, and it's not permitted to take photographs or record any of the meeting. So I haven't had any apologies. Is anyone else aware of any apologies? No?
Oh, sorry.
No.
Liz going to be late.
Okay. And Linda is coming as well. And as I said, we've Colin McGrath and Alan Robinson online. Under Chair's business, the only thing I want to mention is that this morning some of the committee members and along with myself attended the ambulance service headquarters in Knockbracken, and I think others who were there will agree it was an excellent visit. We had an opportunity to meet with staff in the control room to get an understanding of their work, but also the growing complexity of their work and how they're upskilling and updating what they do all the time to try and cope with the increase in demand. We also met some of the students who are going through some of the courses at the centre as well, which is really useful. And we got a really good understanding, I suppose, of the impact of backlogs and pressures in other parts of our health system on the ambulance service and their ability to respond in a timely manner. So lots of food for thought coming out of that. We're very grateful to Michael and Michelle who and the team there who organised and facilitated our visit today. So thank you to them. Members, I'll just refer you to the draft minutes of the meeting held last week, the 26th of September, page 6 of your meeting pack. Are members content with the minutes as drafted? Yeah. Item number 4 then, matters arising. As you'll remember, we met with the families of the deceased patients of Michael Watt on the 10th of September. The department has now confirmed with the clerk that the Minister will meet those family members on the 29th of October. So I think that's a really positive development, and hopefully we will see further progress in around that. I know those issues are of particular interest to the committee. And some of us met, myself and my colleagues Linda and Orlia met also this week with Charles Little, who is the son-in-law of Mr. and Mrs. Caudry, who were murdered a number of years ago by a mental health patient, and he is more than willing, as we discussed last week, to meet with the committee as well, because he and others in that situation have really valuable input, I think, to some of the work we're doing around SIAs, accountability and lessons learned. So I had said to him that we had discussed it last week at committee, and he is more than willing to do that, and along with some of the other families involved in the panel associated with the review or the redesign, of the SIA framework. So I think that would be very, very worthwhile. They have a lot to I think they could bring to the table in terms of our work around that as a strategic priority. Okay, then members, I'll move on to our first briefing, which is with the department, the Chief Dental Officer, and an update on general dental services. If I can refer you to the briefing paper at page 16 in your pack, and there's previous papers also included in the members' pack from page 28. Busy road, how are you? Yeah, Caroline. You're all very welcome, thank you, and apologies, we had to reschedule this from before recess, as you'll be aware, which was very disappointing for us as well, but we are grateful for your time and appreciate you coming today. So in attendance today, members, we have Caroline Lappin, the Chief Dental Officer, Gerard Cassidy, Director of Primary Care, and Michael Donaldson, Head of Dental Services in the Strategic Planning and Performance Group. So thank you all. We have an hour for this session. As I said, we have other briefings later in the meeting. If I could invite you to make your brief opening remarks and then open up for questions.
Thank you, Chair. I'll start and then Caroline will take over. So thank you for the opportunity to brief the committee. I'm Gerard Cassidy, Director of Primary Care. With me are Caroline Lappin, as you said, and Michael Donaldson. I'll quickly cover some of the main issues in GDS and then welcome any questions after that. So under the GDS contract, dentists are paid using a blended system comprising item of service fees, registration payments and other allowances, including pension contributions, payments and reimbursements for general operating costs. Around 50% of overall dental payments are for their IOS, and the remaining 50% is split evenly between those other sources. Whilst the number of dentists contracted to the department has not diminished and a greater proportion of the population is currently registered with a dentist, the overall amount of treatment being provided has not recovered to pre-pandemic levels. In terms of activity, we have 2.4% more patients were seen in 23-24 than in the previous year, and the number of treatment claims increased by 4.5% in the same time. However, over the last 12 months, activity within GDS has been around 75% of the pre-pandemic levels, and recent indications are that it's closer to 80% in the past few months. In practice, this means that registered patients are having to wait longer for treatment, and many unregistered patients can struggle to access care. Last year, the department introduced a number of measures aimed at increasing access for patients. These included a pilot for unregistered patients, a 25% increase to the fees for provision of dentures, and an enhanced children's examination scheme which ran from January to June 23. These measures were in addition to the additional 95 million of support which was provided through the COVID period. On the 27th of March 2024, a further 9.2 million investment for 24-25 was announced to support practices and focus additional funding on boosting activity and access. This funding is being used for the re-establishment of the Enhanced Child Examination Scheme that ended last June. The scheme is designed to address the fall-off in new registrations in the under 10 age group that were impacted during the pandemic, and it supports the prevention of dental disease in early years. The scheme restarted on the 10th of June, and since then approximately 10,000 children have been newly registered. The second element of the funding is to provide a 30% enhancement fees associated with fillings, extractions and root canal treatments, which are some of the highest priority treatment areas. All IOS fees are at least 20% higher than their 1920 levels, with extractions, fillings and root canals now 43% higher than pre-pandemic and dentures 45% higher. Finally, the funding establishes a dental access scheme that is designed to further incentivise dentists to treat unregistered patients. Participating dentists are paid an additional £150 for patients with an urgent need and £100 for patients with a pressing but not urgent need. The scheme commenced in August of this year. There are currently 28 practices participating, with over 2,000 patients being seen in the first 6 weeks. There's an additional 3 practices preparing to join in the coming weeks. Whilst we regularly engage with the BDA across a wide range of issues, due to the pace at which these proposals were developed, it wasn't possible to engage in our usual way. Pressures on the GDS and the need to quickly secure funding for 24-25 resulted in the approval of the investment being pushed forward at pace. We fully expect to engage with the sector in a more planned and meaningful way going forward. Regarding contract reform, significant challenges around access to dental services are prevalent across the UK. The committee will be aware that in November important changes were made to the Scottish contract, with the number of codes reduced and many seeing significant increases in value. We've been working closely with colleagues in Scotland to understand the impact and implications of the changes they have made. However, it's too early for them to be clear on both the costs and effectiveness of the changes they've made. Our own high-level analysis indicates that the implementation of similar increases in fees for Northern Ireland would have significant cost implications, which would in turn raise concerns about affordability given the pressures in the health budget. We will continue to consider developments in Scotland and elsewhere as we progress work to ensure that we are delivering the best possible service for patients. In relation to dental amalgam, the committee will have received specific briefing on that topic. I'm not going to repeat the detail of that briefing, but just to say that, in short, the impact of the regulations would have been an immediate increase in costs for patients, for practices and for the department, alongside a decrease in capacity due to the length of time it takes to place alternative materials. In June, as you're aware, the EU and UK governments agreed a derogation for Northern Ireland to permit the continued use of dental amalgam for patients until the 31st of December 2034 or until a date agreed under the Global Minimata Convention. There are a number of conditions to be adhered to as part of that, and we are working towards these with colleagues in DERA, other agencies and the British Dental Association. I'll pass to Caroline now to continue.
So in terms of oral health, the oral health of the people of Northern Ireland has improved significantly over the last number of decades, which has resulted in lower levels of dental disease for many of our citizens. But the burden of oral disease still remains, particularly among people from lower incomes and those who live in more deprived communities. So, whilst acknowledging that the oral health strategy in Northern Ireland does date back to 2007, I do believe that many of those recommendations and the evidence base for those recommendations are still valid, although obviously the data will differ through the passage of time. But the aims of the strategy are no different to my aims for today, which are to improve the oral and dental health of the people of Northern Ireland and to reduce our oral health inequalities within our society. In late 2019, you may be aware that my predecessor had announced their intention to convene 2 oral health options groups to consider and to develop proposals for children and for older people. Now, the establishment and development of that work was obviously impacted quite a lot by the pandemic. However, the oral health improvement plans for children and for older people were published in December of 2023 with a total of 36 recommendations, which were then subject to a 12-week period of public consultation. We published the consultation report in July of this year, and this consultation report showed overwhelming support for the recommendations from both of the improvement plans. And within the department, we have continued to develop these recommendations, the ones in particular that have the biggest potential to make the greatest impact on improving oral health, but which are also supported by the strongest evidence base. However, these recommendations will require additional financial resources alongside people investment for project planning and implementation. And obviously that is a significant factor at this time of severe financial challenge, which the committee here will have heard many times. I continue in my role to make the case for oral health, and I do believe that there is a real opportunity for change through the necessary update of the Northern Ireland National Plan for Phase Down of Dental Amalgam Use, which will become a plan focused on the phase out by 2035, because our phase out success will be dependent on upstream oral health improvement. Understanding the oral health of our population is being supported by our successful restart a number of years ago of surveying the dental health of children as an indicator for future dental disease. And to that end, the department has funded 3 dental health surveys of 5-year-old children and 1 dental health survey of primary 7 children, with those findings currently being analysed. And these surveys will provide key information regarding the oral health needs of our population to inform future planning of oral health services. Income-related inequality in oral health is a major issue across the UK and not so less in Northern Ireland, with the least affluent consistently having the worst oral health. Our cancer registry data has also indicated that there is a socio-economic gradient for oral cancer, with the risk of developing oral cancer significantly greater amongst those from more deprived communities. Moreover, the risk of mortality has also been shown to be greater for oral cancer patients from lower socio-economic groups. And regarding deprivation, the proportion of Northern Ireland registered with a dentist in March 24 broadly increased as deprivation decreased, with 65% of children who are categorised as the most deprived registered with a health service dentist, compared to 79% of children categorised as least deprived. Oral health is increasingly recognised as integral to overall general health and well-being, and I am committed in my role to ensure that oral health considerations are included in appropriate strategic decisions within the Department of Health. So thank you, and I'll be happy to take your questions.
Thank you, Gordon and Caroline, for your introduction. I suppose the first question, because you have talked around, particularly around the health inequalities piece, and I know the Minister has identified this as one of his priorities, so hopefully there's been some engagement around that with the Minister. But I suppose one of the things, and it has been noted, is the growing move to the private delivery of services. And then I suppose, and I think we did discuss this in the briefing with BD as well, the impact then on NHS patients. I mean, you've outlined there the figures in relation to children who are coming from more socially deprived backgrounds in comparison to those in less deprived. What work is happening, or what work is ongoing within the department to try and tackle those long waiting lists? Because I'm sure that is an impact. What we're hearing from the BDA and from dentists themselves is that in many cases they have no choice, because it's the only way they can make it affordable to continue to open, by having that balance of private patients, given the remuneration as it stands. So is there work ongoing to try and deal with that, to make sure that everybody is getting access to a dentist when they need it, regardless of their income or their background?
Happy enough for me to start about the inequalities bit?
Yep, absolutely.
Okay, so in terms of the health and equality work, which has been a priority for the Minister, yes, we have had engagement in that, and particularly moving forward. It's obviously, it's not going to be possible to do all things in that, but we're looking at the minute around sort of the role of health literacy, because we do know that oral health literacy, for instance, of caregivers and parents of children, whenever that is not good, then that tends to mirror their dental health as well. So I am involved in some discussions within the Health Development Policy branch in the department around that. In terms of what we've been doing for move to private, that is really where our schemes have come in. And I would say at this point in time, we look like we have had very positive engagement, particularly around children for the enhanced child exam, and the data to date shows that we are actually hitting children that are in the most deprived deciles in Northern Ireland with that, and that's just under 10,000 children in the 3 months that scheme has been up and running.
Yeah, I mean, just to build on that, so I suppose in my opening remarks, we outlined at a very high level the big interventions that we brought in earlier this year to try and address some of what you've raised, Chair. The enhanced child examination scheme does provide for children who had slipped through the net of registration to get access to the dentist. I think one of the key things with that scheme is that it's not just promoting registration of the patient, but appropriate treatment as well. So it's not just they're not just getting onto the books and then not getting seen. They're getting fluoridation as appropriate. They're getting advice on tooth maintenance and how to stay healthy in that space. The other significant one is the dental access scheme. That builds on a previous scheme which you might have been familiar with it was called PUPAS. I can't remember what the acronym stood for, but the name of it was PUPAS, and that was really about targeting patients with urgent need who weren't registered, and so that there could be effectively emergency access for those patients. This is a wider scheme, so it widens the threshold of people who are eligible to apply for it. So again, targeting people who otherwise would not have been able to get access, and it's typically people who don't have health insurance or don't have private health care to pay for that. I think it's early days with that scheme, but the numbers are looking promising, I think, in terms of the level of practices who are taking it up and the number of people who have been seen through that. The challenge will be, and it's too early to tell, but once those patients are seen through a scheme, how many of them actually get registered and have ongoing access to dental care. We'll be keeping an eye on that, but it's just too early to say on that. The third scheme then is just around, I guess, recognising part of what you touched on, Chair, around the differential between what is paid in for kind of NHS dental versus in the kind of the private incomes. Within a constrained financial envelope, we've sought to target investment in some of the most impactful treatments, so that dentists will be paid more for doing those treatments in public dentistry. So that's fillings, extractions, and root canals, all of which are the fee for which was uplifted by 30%. I think in overall terms, as I said in my opening remarks, we're now, across all items of service, we're paying 20% more per intervention than we were pre-pandemic. So we've tried to reflect the growth, to pay more to kind of keep that access open. It is very challenging, and it is, I guess it's an ongoing challenge to kind of meet the needs of the population and maintain access when there is the incentive in the marketplace for private dentistry.
And I suppose then in terms of the investment, the 9.2 million as well, there's a couple of parts to this I wanted to highlight. Firstly, I suppose I'd like to understand if the department been able to track just the effect of that investment. Are we seeing, the real impact of it? And secondly, when we had the BDA in June, they had said there was a real lack of engagement. I know, Gerard, you'd said there you'd like to see going forward better engagement. For me, that's a real issue because, they're at the front line and trying to deliver the service. Very, very difficult circumstances. I'm sure you tuned into that session, and when we talk about the costs and essentially many operating at a loss sometimes for some of the services that they're delivering. So I think I would like to think, and hopefully you can talk a wee bit more on that lessons are learned in relation from the department's perspective, because that engagement is so important, that we're hearing where the real challenges are and how we can work together to tackle them.
Yeah, I'll address that part first, if you don't mind, Chair. I think I would say that we, in general, we have good engagement with the BDA, and at multiple levels, not just on just kind of contract and non-contractual engagement, just engagement on regional level. The specific circumstances around that package that was announced, I mean, it's not how we would ordinarily want to do business. It's not how we have done business previously. In mitigation, the proposals that we had been engaging kind of verbally and informally with the BDA on these proposals really through Christmas and New Year, with a view to getting something out before the end of the year that would be for the service. At that time, we weren't, it was shortly before Minister's arrival, so we kind of felt, well, if it wasn't appropriate to be making an announcement for kind of making claims on the future budget with a new minister coming in, so we didn't progress at that point. When the new minister came in, then we were, there was less time, so we were keen to get the proposals agreed and out as quickly as possible before the end of the year. We didn't have time for the usual in-depth engagement we would have with the BDA, but they would have been aware of, at a high level, what the contents of the package were going to be, and like I said, one of them was a recommencement of the child dental scheme, which was a much a known quantity. So we didn't feel like they were controversial measures that they would have specific difficulty with, but completely accept that we would want to engage much more openly and much more early going forward.
And has there been any engagement since that, or even from we've met with them in June, in terms of moving
Not
forward?
on those issues specifically, but there's been
a number of meetings about last week before was the last meeting with BDA?
Yeah. So SPPG, so I'm the head of dentistry in SPPG. We met with the local dental committees at the beginning of September, and this was talked about at that meeting. And also then there was a meeting with the BDA, meeting on the current contract and the schemes included as well 2 weeks ago.
And I'm presenting at BDA Council in 2 weeks' time, I think it is. So there is, but I think we're all agreed we'd like the engagement to be more moving forward.
Okay, no, that's fair enough. I suppose just the last thing is around the Scottish model, and obviously, they have said that would cut down admin. It's a lot simpler to use, and obviously there's a greater remuneration. And Grode, you said even in your briefing there around the cost, the affordability of it. Do we have an understanding of what that cost looks like?
The very short answer to that is nothing reliable at this point. So we've been in active and ongoing engagement with Scotland to try and get a handle on the detail of how it's working out in practice and the costs associated. And I think we've been fair to them. They haven't yet got a handle on that themselves. So it's a complex enough set of changes that they've brought in, whereby you've got what would have been kind of several codes for related activities now in a single code, and then it's very hard to make a like-for-like comparison with activity that would have been done under one code when it's now under this umbrella term. So there's detail to be worked through. We would need to have a decent understanding of how the costs have worked out in Scotland, and also how that may have changed kind of behaviour or changed, the type of service that dentists are delivering based on the kind of the incentive model under the new contract, which we don't have yet, before we could make a realistic assessment of costs here. At a very kind of quick look at it, we know it would cost more than what we currently have, and we know that in our current financial budgetary position, we don't have any more that we could put to it. It wouldn't be possible to put a figure on that at this point in time, but as that analysis progresses, we'll certainly share it with the committee.
Yeah, it would be good for us to have that, because I think if it's something that will benefit the sector in terms of the ability to deliver the service, and then obviously the effect on patients, so that people are getting seen quicker, avoiding further issues. I mean, yourselves, we're talking about this in every element of our health and social care service, then that invest to save ethos should come in. So I appreciate we're in a very, very difficult situation financially, but I think it would be good to get that information, because
it'll allow for informed decision making about where priorities lie in effect. So,
even I think at the minute, without having those costs, it's difficult to even say that affordability is the issue here if we don't really know. I know you're saying that looking at it, it'll cost more, but is that a short-term cost? Is that a long-term cost? Is it something that over time then we will see other savings because of people being seen and maybe not requiring emergency dental treatment, which maybe could cost more, puts further pressure on the system. So it's looking at all that in the round. And I understand that's probably what you're saying in terms of your understanding of it. But I think it's maybe, and this is only my interpretation, correct me if I'm wrong, but I think it's unfair to say that at the minute affordability is the main factor for us not implementing it, because we don't really have all the detail yet. Is that fair to say?
Well, I mean, I'd say the reason we haven't got proposals on it is that we haven't got an evidence base yet to support proposals. So we can't make an assessment now that this is definitely unaffordable, and we're not making that assessment. Okay. But, you know, I suppose if we're thinking about what we can deliver and how we can improve things in the kind of short and medium term as well as the long term, our focus is on trying to maximise the budget that is available to us. So the 9.2 million that we discussed in that package, that was, you know, in effect, due to the downturn in activity, what would have been the budget available for dentistry wasn't getting used because there was less dentistry getting done. It's a demand-led budget. So we're trying to be proactive in saying, okay, anticipating that there might be a level of, unless there's a big uptick in activity, we can expect that there'll be, you know, an underspend versus what we budgeted for. So how can we then proactively use that budget to boost activity and boost access for patients? Now the challenge is that it's not a ring-fenced budget for dentistry, so any slack in any budget, there is a host of pressures in health that have got like a very good claim for any funding that's there. So it is a challenge, but it's one that we're actively engaged in.
Okay.
I think, Chair, just to add to that, the Scottish model is just one of the models across the UK. So each of the 4 areas of the UK have a different delivery model. We're waiting any day now the new contract offer that's being made in Wales to become known. I do not know the details of that yet. People might be aware from the coverage on media of the English position. We have vociferously engaged with Scotland around this. The reality is that it's still very, very early days for them to be able to say with any certainty what that picture looks like. Policy colleagues have been engaged, and I've been engaging with my counterpart in Scotland, and it's not that they're holding back in this. They just simply do not have the data that we would need for the informed decision at this point in time, but we will keep working with them.
I appreciate that, and I suppose if we could keep it,
Yeah.
because I don't think we don't have the luxury of time on a lot of this, because we're losing dentists as the longer this goes on, which obviously has a broader impact on all of our citizens. So, look, sorry,
I didn't mean to cut across it, but just say, I mean, we're not waiting on getting the data before we try and do things proactively to improve things. So, I mean, we are focusing on how we can maximise our current resources to the benefit of patients and to the wider system, and we're not waiting and holding our breath until we get a piece of information from Scotland or anywhere else that will give us like the path forward.
Okay, thank you. Good. Look, I don't want to, I'm hogging the meeting now, but I know other members have indicated. If Danny, Deputy Chair.
Thank you, Chair. Obviously we've referred to the contract reform there element. Is there a timeline for this? I don't know if we got that off you. Certainly the Doctors and Dentists Review Body report said that it is clear to us that there is current contractual arrangements that are not enabling NHS dentistry to be sustained or to grow. So obviously it's in a very poor health and deteriorating. I think you had mentioned that we were 75% of
pre-COVID activity
work. That's a huge deterioration in the amount of work that's being carried out. One other issue I know my colleague Nola had been working on was about maternity pay for dentists. Now there seems to be a discrepancy in the way that is calculated. Some earnings are considered and some are excluded. I don't know if you'd be able to talk to that a bit to make sure that maternity pay is consistent across dentist earnings. And the other thing I wanted to talk about was, engagement had been mentioned there as well. You'd said you feel that there was no engagement with the BDA on the unregistered patients scheme. That was delivered in haste. Well, not in haste, but delivered very quickly because of constraints. Is this normal? And you'd mentioned you have a good engagement with the BDA. Is this something you want to seek to grow on? Go on.
Well, I'll cover off that. I mean, no, it's the how the last kind of package was agreed and announced was atypical, and we would Like I say, I would say we have good ongoing engagement with the BDA. We certainly want to build on that going forward, and you know, I'm aware that they felt, you know, that they hadn't been properly engaged on that point, and we will and have been making best efforts to make sure that that is improved going forward. On the specifics of the dental access scheme, I mean, it was an enhancement to a scheme that had been in place previously. So effectively, we had the PUPA scheme, which was for patients with urgent need. This widened the criteria so that patients with kind of slightly less urgency would be eligible, and therefore widen the base of people who could avail of it. Again, we would, and we in the future we will have better communication and engagement going forward. But I don't think it was such a novel scheme that it was, that it was problematic in that sense. But we would recognise that we would need to be better engagement going forward. In relation to the reform for the timeline for contract reform, I mean, I don't have a set. We're working with urgency to. We recognise that there is an urgent need for clarity on the way forward and the future of the service. There is, I guess, there's we talked about Scotland, and Karen's mentioned, there are other developments happening which we're keeping abreast of, but we are keen to make plans for Northern Ireland that, ideally will reflect the best of what's happening elsewhere within as far as we can take them. I would say that some of the schemes, like the enhancements that we paid on the extractions and those things, those are very much in line with the kinds of measures that have been taken elsewhere. Like in Scotland, for example, there was those enhancements. So even though we haven't necessarily got a single strategic piece to say this is exactly what the future looks like, we are making steps across a number of areas to try and advance that agenda. I think our focus, as I've said, is to look at where we can maximise benefit for patients, access for patients, and benefit for public sector dentistry within the existing budget, because I don't have a realistic prospect that we'll have significant additional funds available to us. It'd be very welcome if it would, and we would plan on that if that were possible. But I think the argument over significant additional investment will really hinge on that a very strong evidence case from elsewhere about what would be deliverable here, and the impact of that on what we could expect to see here, both short term and long term. But we are making, trying to move forward in a kind of strategic way so that we can be responsive to the needs of the service going forward. On the maternity pay, do you want to start?
It was brought up at the meeting I mentioned a couple of weeks ago with the BDA, and at that meeting the BSO were also represented, and BSO undertook to go away and provide the calculation that they use in determining maternity pay. It is set out within the Statement of Dental Remuneration, Determination 5, but it maybe lacks a little bit of detail. So I think when BSO are able to share their calculations with the BDA, then we'll understand a little bit better what the issue is. We in SPPG did take legal advice on one element of maternity pay, whether payments that were made under the oral surgery pilot scheme at a practice level were eligible for maternity pay, and the legal advice we received is they are not. If it's made at a practice level, those types of payments are not superannuable, can contribute to maternity pay. So that's our legal position on that element anyway.
Thank you very much for that. Just to expand on that, typically as a constituent office, one of the big problems we get from people coming in is that they have no access to public service dentistry in our area. It just doesn't happen. It's progressed to such an extent, and obviously we've heard from dentists just saying that it's financially unsustainable for them to be able to be in that model. So any progress in contract, it obviously would be very, very good at being able to turn that back. You'd mentioned the 4 delivery models across the UK. Are you learning from that? I know you've talked a lot about the Scottish model. Is there learning here from it?
I suppose Scotland, Danny, has been the one that is referred to quite a lot in Northern Ireland, because essentially Northern Ireland and Scotland didn't make the changes that England and Wales did in 2006 when they moved away from essentially a suite of items that we pay for people to deliver. So it's a demand-led budget. So, my professional colleagues will make references to Scotland probably greater than England and Wales, because it is a very, very different system. So Scotland their changes haven't been so much around contract reform, but really around how people are paid for delivery of the work. So the Scottish offer was not a diminution of the contract as it stood, but a different way of being remunerated for delivering that. And that also involved then an uplift to a number of the fees across the board, really, with substantial uplifts to laboratory-based fees, which in fact we have also given a significant uplift by 45% to laboratory-based fees, recognising those increased costs on that particular type of item. England and Wales, you may be aware of, they refer to units of dental activity, which in Northern Ireland we wouldn't be able to refer to just as easily for reasons of the acronym, and that, you will be aware, has been subject to a significant amount of media attention. It's problematic in terms of the delivery. Obviously you'll know in England and possibly in parts of Wales, people refer a lot to dental deserts, and essentially contractors, they contract differently. They are literally handing back contracts and saying we will no longer be delivering health service dentistry. We don't have that particular dental desert type arrangement to the same extent, because it's demand led. You may still, as a contractor, have patients registered on your system, but our registration is for 20 up to 25 months. England and Wales do not register patients. There is no such thing as patient registration, so it's different again. It may well be that in Northern Ireland, dentists will, rather than totally removing themselves from the health service, they are just reducing the amount of clinical hours that they spend on health service dentistry. Therefore, they are spending more time on other delivery models. So there are certainly aspects of what was the previous government in England, of what was called their dental recovery plan. It's still unclear as to what that's going to look like under the new government, but there are elements of that we would be looking towards, which are, as I mentioned in the opening statements, evidence-based in terms of supervised toothbrushing, things like that, which may or may not be part of a contractual model. I don't honestly know the detail of what's going to be happening in Wales. I know bits and pieces of it, but that offer will become known in the coming days, we hope. So I do think it would be wise to look at all of those. I suppose what I would say, and I don't know professionally if Michael would agree, across the UK, I don't think any area has come up with the ideal model. They all still have issues, and certainly, my professional colleagues in Scotland will not say that this has been the absolute golden casket. It's better than where they were, but it still isn't where they want to get to.
Yeah, I mean, it is a UK-wide problem. I suppose in a way we have come from a very positive position UK-wide in terms of access to health service dentistry, access to state-provided dentistry. That's quite an unusual model at the European level. Most countries do not have state-provided dentistry to the extent that we would have. So, in a way, we're not as good as we used to be, but in terms of state-provided access, we're better than most European countries. So it's a very different model that we have. Most European countries operate on an insurance-based scheme, where the tax element of it is minimal. We're very different.
Okay, and just one last quick question just about amalgam. Great to hear about the derogation. I'm sure that went down very well. You mentioned a phase-out plan.
Yeah.
So is that developed, or is that just in the early stages?
That's in the early stages. So back in 2018, 2019, each area under the Minamata Convention had to develop their own national plan for phase down of dental amalgam. We are obviously going to be in a different position now, where the derogation is such that by 2035 or sooner, if Minamata changes, we will be going to phase out. So that, obviously this derogated period provides us with almost 10 years to get to that position, which is infinitely better than where we thought we were going to be on the 1st of January 2025. But that we won't be able to actually get to that position without the proper planned approach. So there's ongoing engagement with Cabinet Office colleagues in the UK who engage with EU around this and how we're going to put these derogations into place. We're obviously going to try and do this with the minimal intervention for both practitioners but also for patients, and we do it in a phased way, perhaps building on where we are already in that children under the age of 15 and pregnant and breastfeeding mothers do not get amalgam fillings unless clinically necessary. So it's building in on that on a phased approach. But we'll get there.
Okay, thanks, Danny. Colin, I have you down, but I don't know whether your hand's down there, so I can come back to you. Alan Robinson, did you still want to come in? I know your hand's down now, so I had you on my list here. No. I'll come back to you if you can get unmuted there. Orlia?
Yes, thank you. Thanks very much for all of your feedback and comments so far. So just to come back to the issue of the oral health strategy. So I know that it was saying in the briefing paper, and obviously we're all really aware of the budgetary situation and right across the health service at the moment. So you are limited in terms of how you're spending your money and what on. But it says in the briefing paper that basically any plans for a new strategy is on the back burner because of the cost that would entail, and you are trying to invest in other things in the meantime. But it says it would be a significant cost to design a new strategy, and I would just be interested to know, because it does mention that the strategy does remain, most of it remains fit for purpose, and that if it's just a case of updating some of the data, which was obviously collected a very long time ago, can you break that down, what that significant cost would or does mean?
Do you want me to start, and then as my resident dental public health consultant? So I suppose, the big thing is, yes, an oral health strategy would essentially require to bring in a number, 1 to at least experts to do a fairly deep dive into population, into things that have worked in the past to improve oral health on a population level, and really provide a baseline at a whole population approach to see where we go from. That's more of Michael's bag than mine in terms of dental public health. But I suppose what I'm saying in that is, if funds were there, we could do the all singing, all dancing approach, but will it change from where I feel we are going to be best, getting value for our population, and that's really why we've been then concentrating on those most vulnerable groups, because we do know that, for instance, take children, if we develop good habits in early life, then those translate throughout the life course. We're obviously in a different position now across our population in terms of our ageing population, who, due to the success of holding on to teeth, are entering older life now with natural teeth. So those were the reasons for focusing in on those two groups. It's not that the middle population is going to be left to look after itself, but I suppose even looking at oral health improvement for older people, it's about trying to prevent that disease in later life, which automatically hones in on younger adults. So, I know we've lots of talks about strategies and lots of different departments, which could just sit on another database or another shelf. The idea behind the improvement plans is they had actual actions that could be translated into activities and interventions, which are essentially the outworkings of a strategy. I suppose the evidence base in dentistry hasn't changed significantly across the years. We know what the big items are in dentistry that work, in terms of fluoride, in terms of reducing sugar frequency, and in terms of behavioural aspects and all of that. So it's trying to tie that in. But for me, from my role within the department, I feel that there is a value, rather than a standalone piece of work, in building on the other pieces of work that are going on across other branches and directorates. So for instance, in terms of, although we have the oral health improvement plan for children, we have been involved in work that's gone on in the Chief Nursing Officers Group and PHA around the early advice for mothers for young children. We've been involved in the work under Mark McGuckin's directorate around the Enhancing Clinical Care Framework for older people in care homes. So it's more about that broader approach. If I had a team of people to put together a strategy, that would put us in a different position, but I am where I am with that. And for me, it's really the outputs and the outcomes which will be more important than having a fancy strategy as such.
Yes, no, and I totally agree. And the reason I was asking a question around the strategy was for that exact purpose in terms of what the outcomes are. And so it doesn't matter if it's a strategy or a health improvement plan or whatever it is. It's then how are we monitoring that we are getting the right outcomes. So I suppose my question would be in terms of, and I know that with the oral health improvement plans and the one for children and young people, it was saying that there is some really, really good, ambitious recommendations that you have in those plans. But then it's going to be a case, I'm assuming, of coming down to funding how much of those recommendations you can implement. But what my question would be then is going back to the data that we're working off from 2007. I know there's been different pieces of work you had mentioned with the under 5s and the primary 7s that has been done. But how are we actually tracking if the work that the department is carrying out is actually making any difference? So the big stats I'm thinking of is, again, the children in the most deprived communities as opposed to those in the least deprived, who probably have still the highest attendances in the children's hospital and are having to get those surgeries because they're not registered with a dentist and they're ending up with oral diseases. So my question is around that. How are we tracking if we are making any impact, particularly for those kids in the most deprived communities? And I know that I've seen in the surveys that was carried out, so the survey that was carried out with the 5-year-olds, the results are pending from a survey in 2021-22. If you could maybe just explain a wee bit on that. And then it was referenced in your opening remarks as well around across the UK there has been improvements in oral health, but that's actually going off data from 15 years ago, from 2009. So how can we stand over improvements if in the briefing paper it's saying that that's actually around adult dental health from 2009?
Michael will speak around some of that data, but I suppose the other thing I would say at the minute in terms of our GDS contract, albeit not where we want to be, it does provide a wealth of data in terms of the treatments that are being provided, which are obviously treatments because there is dental disease present. So we can actually track through that data, the number of fill-ins being placed, the number of patients being seen for routine examinations, recall. We can look at gum disease, treatments, all of that, which provides some level of a data set around that as well.
Okay, so in relation to the 21-22 survey, so the actual field work, the dentists going out there to the schools to look at the children's teeth, to record the information, doesn't normally finish until maybe April, May in any given year. So that won't have finished until 2022. Then it has to be collated up, the data has to be cleaned. We don't analyse it here in Northern Ireland ourselves. It's analysed in England to be done in exactly the same way as it's done in England and Wales by the same statisticians, so it's all comparable. That takes some time to come back. We do actually have the results back for 21-22, and we have the report in draft form, probably only a month of completion, but we have the figures, and we know from that quite a lot about the oral health of those children, that it hasn't changed really massively over the pandemic, for example, that health inequalities haven't really widened to any great extent among 5-year-olds. So we have all the key indicators that we need, but it's just not published yet.
Okay, and in terms of the hospital admissions, are you tracking those?
I mean, we would have access to that information. It's the number of children receiving a general anaesthetic each year in Northern Ireland for dental reasons has decreased from before the pandemic. It's about 90% of what it was before the pandemic. That's more to do with access to those services. It's got access to theatre lists, it's got theatre nurses are part of the issue as well. Before the pandemic, the numbers of children receiving a general anaesthetic were on the decline anyway, from about 5,000, say, in 2009-10. So we were in the right trajectory, but the pandemic did set us back. But we're definitely, almost month upon month, we're getting more capacity to catch up on those cases which are on the waiting list, as it were. You will find that the children that are being seen under general anaesthetic, so there's about 3,322 or 24. Those children are predominantly from the more deprived, disadvantaged areas. That's absolutely the case. So what we see in the pattern of oral health in Northern Ireland is really dramatic improvements over the last few decades and the population as a whole. But in the most deprived quintile, 1/5 of the population, not much of an improvement. So we were dealing with a group where we really need to focus our resources, and that's why our oral health improvement initiatives are generally targeted at the deprived communities, deprived groups. That is a key element of our Happy Smiles programme, for example.
No, I appreciate all that feedback, and thank you, Chair. I think it would be helpful, maybe, hopefully, as you can progress some of the recommendations out of the health improvement plan, and maybe when you get the data published and compiled from the survey, it would be helpful to share that with us so we can just keep a wee track on how that's going. Thank you.
Thank you. Diane?
Yeah, thank you, and thank you for the presentation. It is very helpful. Can I just pick up on just a couple of things very quickly? So is there data, and I just don't know where to access it probably, on the dental access scheme? And if that could be shared with us, and so that we can have some qualitative notion of how successful or not the actual scheme was. So that's a relatively easy thing. I see everybody nodding and saying yes, that's fine. The other thing that I wanted to ask was around the contract. We've talked a lot about the contract, about the difficulties of the contract, about looking at other areas of contract. Have we any timeline for getting the contract? Because as long as this continues, we will continue to have a shrinking NHS dentistry in Northern Ireland, and we need to fix it. So is there a timeline? And if so, do we know what it is, Caroline? I'm going to look to my colleague here in the Care Policy Group.
So on the first point, I mean, on the dental access scheme data, I mean, absolutely, it's very, very new. Just, I mean, it's only been out for 6 weeks, so, or a little more than that. So as we have...
Really interesting, though, to see how it's working.
Yeah, no issue at all. In relation to the timeline on the contract, I mean, as kind of said to the previous question, we don't have a set timeline on, a grand new unveiling of a new contract. We have been, and we look working on making incremental or iterative improvements as we go along, and learning from the best examples of what's happening in Scotland and elsewhere to help inform that. Our focus is on, as I said, making sure that we can maximise benefit to population, improve access for the population within the budget that we have available to us. We will be looking at, as we did for this year and the 9.2 million kind of repurpose and those schemes. We will be looking at what more we can do in that space for next year. But so we will be looking to make for the next contracting year. But it's not to say that will be like the final word on a new substantively different overall contract.
Okay, so that's a negative response then. We don't have a timeline and we can't give a timeline. Is that what we're saying?
Well, no, it's more that it's more of an iterative approach to contracting than there being a fixed end point after which then the work is done.
Yeah. Apart from looking at everybody else's contract and what they may or may not do with their contract, I really wanted to get to the stage where we understood the timeline for one here in Northern Ireland and what the specifics of that would be to Northern Ireland. And I'm not hearing an answer really in relation to that. And I think that that's a difficult message from this committee today, because I do think that actually means that we're going to get more of the same. And I know that you're making improvements at the fringes, but I do think that will be more of the same unless some of the data coming out, for example, the dental access programme tells me that it's tremendously successful and is picking up the slack where there is no access to dental treatment. And I do think that's a negative message, to be honest, coming out of the committee today. And I think it's something that we need to take away and look at and work a little bit more on. Chair, just with your forbearance, just one other thing that had come to my notice during the summer, and I asked some questions on this during the summer, or before July, probably, about non-domiciled companies offering dental consultations in Northern Ireland. And I just want to know, could you tell us about the extent of that practice and who is regulating and how are we making sure people are getting appropriate treatment?
Okay, so we have noticed an uptick in Northern Ireland in particular from non-domiciled companies coming over, usually at a weekend, and doing a pop-up event in a hospitality type venue. So this is quite difficult because what we don't know is the extent to which the interaction is. Okay, there is nothing to stop a company coming over and speaking to the public and advising that you can go to another area to have dental treatment. What is illegal is what is defined as the practice of dentistry. This is an area really that the General Dental Council are involved in because they are the regulators for dentistry in the UK, and you must be registered with the General Dental Council in order to carry out the practice of dentistry. Now, every
Can you differentiate that for me?
I knew someone was going to ask me that, and there's never a good answer to that one. We can't. The practice of dentistry. You know, me sitting and telling you how important it is to brush your teeth and do it twice a day. It would not be defined as a practice of dentistry. The practice of dentistry would be carrying out a intervention on you as a person, some sort of dental intervention on you.
So if someone was to check teeth and say you needed 2 fillings, but didn't do the fillings, is that?
It depends who you're going to ask about that one, okay? And this is where we're, this is a problem across the UK, and it seems Northern Ireland is one of the places they're focusing on them. And you may see on the adverts that these companies are putting out on social media, they of late are putting an exclusion box in the bottom saying you will not have any treatment carried out, you will just talk to a dental professional, your treatment will all be carried out outside of the UK. I've had numerous meetings, and you've attended as well, Michael, with RQIA, because obviously to carry out provide a dental service, a premises must be registered with them, and those who are working in that premises must be registered with the GDC. But these companies are coming in and flying straight back out again. Once they're out of the country, we have no legal jurisdiction on them. I would say there's some frustration.
We also have no corresponding safety guidelines for patients who may go for a consultation.
We do.
We do.
We do. There is information
right, okay.
available through the RQIA that has been it's been advertised quite recently on social media. There's also advice available from the General Dental Council. I'll happily pass that on to the committee, advising patients that if you are going to attend a pop-up consultation event, that you should, the questions that you should ask, and plus if you seek to have treatment then carried out outside of the UK, that treatment may or may not be carried out by a dentist who is trained to the standard that they would be in the UK. It is frustrating. Local dental committees have been in touch lately about it. It was brought up at non-contract meeting as well. I have had meetings with GDC about it. It's on the agenda for a meeting in a couple of weeks' time with them. It's a very tricky one to stop. We can't take away patient choice, and patients have the right to go and seek treatment in Turkey or wherever they want to go, and we can't stop these companies coming in, but the RQIA have been making the hotels aware that they may be, as soon as RQIA have known, they've written to the facilities and said you may be hosting an event, and this should not involve any treatment of dentistry, which would be an illegal activity in your premises. It's very, very difficult to change. Anything?
No, I mean that's completely it, the position.
So again, it would be really useful to have that. This arose in my office as a constituency case.
Yeah, it seems to be quite widespread at the minute. Certainly, it seemed to be very centred around Belfast, but I've become aware it's actually stretching around hotels throughout Northern Ireland as well.
Okay, thanks, Diane. Danny's looking to come back in as well, and I just had 2 quick ones, I suppose. Just on the back of that, I suppose you're seeing a growing trend in the impact of people who are going abroad to have dental treatments and then not having a good experience, and then dentists here having to pick up that and deal with the issues surrounding that. So, and we're seeing that across different treatments, but I think dentistry is probably one of the biggest ones, because people are going to various countries for those treatments.
A lot of the treatment, though, Chair, that they're getting abroad would not fall under what would be health service treatment anyway, but certainly anyone who comes back and is in need of emergency care, they can access that. There's no issues at all, but it tends to be generally speaking here, people are going abroad for implants or full mouth zirconium crowns seem to be one of the most popular, which would not be a health service treatment anyway. I do think that and it's the same in medicine, patients in general need, it's not just as easy as getting on a flight and undergoing the Hollywood smile and coming back and everything's changed. They need to take these things into consideration, but it's obviously it's an attractive thing to do because the costs could be a lot lower than seeking the same treatment here.
No, absolutely, and I know it's not something that would be done under NHS, but I suppose my concern is around the complications and when they run into problems after, and that's becoming a real issue, and we've seen that even in terms of other aesthetic treatments as well. So I think it's something that not only is a safety concern, but it also adds pressure in terms of the service. The only other very quick one, I know Danny you wanted back in as well, is Michael, you had mentioned around when we were talking about the Scottish model, and I'm conscious of time here, but just to highlight this, you had said colleagues are saying it's better, but it might not be the best. Have we any sense of other models that could be better again, that might work better? Are we looking outside of that? I don't know what it's like in the south. We've talked a lot around England, Scotland, Wales, but I think if we are looking at developing a better model for people in the north, for dentists here in the north, and for patients, then we should be looking at all other models. If that's the case, we certainly from our perspective, we want the best outcome for everyone involved. So I just think it was just interested to know, was there anything else that you were aware of?
Depends how radical you want to get, really, with this. So, I mentioned earlier about the relative expenditure in different European countries, government expenditure. So, Republic of Ireland about €40 per person per year, in Northern Ireland about €90 per person per year, state for dental care. And there was a survey about 10 years ago, maybe a little bit more, of the general public, asking them, what is the most important thing for you in dental care? Is it to have ready access to basic dental care, or is it to have maybe not such good access to more comprehensive dental care? And overwhelmingly, they chose the former. So quick access to basic dental care is what the public seem to want and want to prioritise. And that happens in other countries. They put the resources into trying to do that. So that's a very different approach. One that could be considered, I would suggest. As I said, depends how radical you want to get.
The model in the south is, again, it's not a comprehensive care model. It's very insurance based.
Yeah. Obviously, they have a whole different system
across. They have other issues there in terms of water fluoridation, all of that sort of thing, which is different in Northern Ireland.
They also have better control over their budgets, but that's another story. No, look, it's really out of. I have no suggestions around that. I was just interested to know, because you did say, obviously the BDA have been very. They've advocated around the Scottish model and see the real benefits of that. If I felt there was something better again that would benefit both dentists and patients, then I think it's worth considering. But it was really just out of curiosity. Sorry, Danny, and then we'll conclude.
Just a couple of quick things. It seems to mirror where we are with health waiting lists, that people are being forced into a different model now. So you're effectively being forced into paying for it. People literally are being forced in because they don't have any other option. When you said that you don't think there is a dental desert, I think people would disagree with that. I think a lot of people would say there is dental deserts here. If they can't get on books for private or public dentistry, that's a desert. That is maybe not like Birmingham, where the people were queuing up all night and all that, but certainly that does exist for a lot of people who are coming into our offices.
I think the difference here comes with our registration. So essentially, if you're a registered patient at the minute, you're not in the desert type situation. The big issue is around patients who aren't registered, okay, and trying to get seen under health service arrangements. And I would agree with you, private isn't really paying for anything hugely different, but it's paying for quicker access. So it may well be that you would get seen under health service arrangements, but it would be a number of months before you will be seen. Whereas if you go privately, you could be seen quicker, which isn't a space as a dental professional that I want my profession to be in. And again, the picture isn't the same across Northern Ireland. There are areas where waits are relatively short and areas where waits are fairly extensive, and that would be mirrored probably over the months in correspondence from yourselves and your colleagues, where some areas are much more of an issue than others. So I don't deny that there is a problem. It just isn't the same extent. We still have, if we look at our statistical information, is it 95% of the population in Northern Ireland live within 5 miles of a dental practice? You can't say that in other areas. For instance, Dumfries and Galloway in Scotland, and we have the Scottish model, there is not one health service dentist in the whole of Dumfries and Galloway. So, we aren't at that stage. It's not a stage I want to get to. And certainly the dental access scheme, we are pleased in that there is a spread of practices across Northern Ireland. They're not all in one area. No, they're not. There's not as many of them as we would like. But certainly they're, in seeing upwards of nearly around 500 patients a week, it is helping. It's not providing the full solution, but it is helping. But the like of that, Dumfries and Galloway is not a place where I would like us to be.
Okay, thank you all very much for that. And as I say, we want to be able to be kept updated on a lot of the things that we'd raised today. It would be useful, and hopefully we can see some progress in some of this. So appreciate your time. Thanks very much. Okay, members, I know we have quite a big crowd waiting on us outside for the next section. So
Chair, could I just follow up very, very quickly?
Yeah.
Is it possible to write to RQIA around the issue of these companies coming in and what regulation or safety that they can propose for us?
yeah, I think so. I think it would be useful. It's a growing issue.
Yeah, I think just so that I have a sense of it. I have no sense of what that looks like.
I think it's a very precarious. Some people have really good experience, and others there's just some horror stories out there. So it's about making sure people are well informed before they
make a
those
choice.
decisions. Yeah.
In some ways it's good that the horror stories are covered, because that's what actually gets people's attention is, oh my God, is that what could happen to me? I'm not saying it stops them all from making, couldn't even,
No, but I mean, even last week there was a story around anaesthetic treatment, a woman in England that died when going abroad. Sorry, Colin, you looking back?
Yeah, I just wondered, thank you, Chair, maybe should we write to the Minister just to ask about that contract, because I don't think we got a real commitment that it's any closer. And I do have that concern that we get briefings like we just got there from the department that would almost suggest that everything's kind of all right, but yet we all meet dentists and we all meet the BDA who tell us that things are absolutely terrible and very close to collapse. So, it's maybe just that a briefing is fine, but if they just go out the door, and I don't mean just specifically the ones that have been with us there now, but if we're going to have a briefing and it's a great disparity from what we're being told by the sector, I do think it's incumbent upon us to follow up with the department to find out how they're going to close that gap, or are they aware of that gap, or are they working towards closing that gap? Because otherwise all that we're doing is really sort of expelling a lot of hot air.
Yeah, we can certainly ask that, and we did press them on that as well in terms of what we'd heard when the BDA were in committee, and in relation to what engagement's happening and what's actually happening in terms of partnership working. So I'm happy to ask for that update as well. Okay, members, so item number 6 then is the review of children's social care services, and we have a briefing from the Reimagine Children's Collective. So I'll just give a few minutes till they come in. If I can refer members to the papers from page 138, some of which you'll have seen before, but it's really just for reference, I suppose, for today's session. are. You're all very welcome. I'm sorry for keeping you for a few minutes over there. In attendance today we have Alicia Toll, Chief Executive of VOIPIC, Kathleen Toner, Director from the Fostering Network, Michelle James, Head of Bernardo's, and Sheena McMullen from the Campion's Advocacy and Policy Advisor from Action for Children. So you're all very welcome and we really do appreciate your time today. This is a priority for us as a committee and we want to have as much engagement as possible, so thank you. We have about an hour for this session and it will be covered by Hansard. So just if I can invite you to make your opening remarks and then I'll open it up for questions.
Okay, thank you, Chair, for the invite to present to you today and to share our experience of the implementation of the Children's Social Care Review and the impact on the children, the young people and the families that we serve. We're going to start over here with Alicia and then we're going to move to Kathleen and then to Sheena and come back to me at the end, and then, as you say, that would be really good if we could get some questions at the end too. Okay, Alicia.
Okay, thank you. And thank you for the opportunity to speak with you today. So VOIPIC, or Voice of Young People in Care, we work with children and young people to promote and protect their rights, voice and participation in all decisions affecting their lives, and we do that locally, at national level and also internationally. We facilitated the Experts by Experience reference group to the independent review, and they engaged with and advised the review team, and much of their work and their thoughts and priorities are reflected in the report and the recommendations that were made. They categorised their priorities into 5 key themes, and the first of those was the participation of children and young people. Children and young people want to be involved in the plans and decisions made about the services, their care and their lives generally. And we have seen 60% of the 416 young people that we supported through our advocacy service attending and participating actively in their care planning. And of those 249 young people, 196, they needed direct support from an advocate to attend. So only 53 were able to attend care planning or participate in their meetings without an advocate. Advocacy services and independent advocacy services are crucial to support that meaningful involvement of children, young people and their families. And they're keen to be involved and engaged in the ongoing outworkings of the review. Their second theme was social work and the workforce. Young people tell us day in and day out they have difficulty accessing their social worker, they want more time with their social worker, and unfortunately we're hearing young people talking about the busy workloads of the staff that are there to support them, not wanting to call on their social worker when they are in times of crisis because they're aware of others in need. And I don't think that's something that young people really should have to contend with and think about. Young people value the role and the relationship that they get with their social worker when that's working well, but they also recognise the benefits of having other key roles in a multidisciplinary team that's coordinated with others and other services and can be actively involved in their care, making sure that there's always someone there to help at times of need or in crisis. And that extends to flexibility to respond outside of Monday to Friday, 9 to 5. Where young people live was the third key theme, particularly for young people with a care experience. They recognise and value the role and the range of care placements and settings that meet the needs of individual children and young people. And they want all care placements to be of the highest quality. They want no placements to be deemed as a placement of last resort. They want better support and better training, including financial support for foster carers and kinship carers. And they want to tackle the regional disparity or the postcode lottery in terms of how children's care and services are structured and delivered, and in particular what children and young people can expect and are entitled to from their corporate parent. And that's particularly an issue for young people leaving care. The fourth theme they identified was transitions. So the need for better transitions for young people moving from children into adult services, that's across disability services, mental health services, and better support for young people leaving care, and whether that's when they turn 18, although too many are leaving before they turn 18, or whether that's being returned to live with parents or families. Care leavers as a group were really negatively impacted by the COVID pandemic. It affected their education and training, increased their social isolation, had detrimental impacts on emotional health and well-being, and they're facing real financial difficulties in a cost of living crisis and a lack of good quality accommodation and support. We know a review of leaving and aftercare services has been completed, but we've yet to see it being published. The full implementation of the 2022 Adoption and Children Act, which would improve and extend provisions for some care leavers, has also been delayed due to financial and workforce constraints. And that's also having a huge impact on adopted families and the support and the services that they receive. The final theme, number 5, was care experienced parents. They, as a group, feel under great scrutiny, they feel judged, they experience discrimination, and often report poor levels of support. Advocacy support is crucial for these young people, as it is for all parents involved with children's services. Just on the table. I'm sorry I didn't. We will send a copy of this pack, but it's just a paper here to reflect some of our advocacy casework across all ages and all placements. And they really reflect the most common issues. Again, what young people raised in the review, but it's also reflecting that real change hasn't happened yet and outcomes are not improving. So we will see in our top issues coming through our referrals to the Advocacy Support Service is a lack of appropriate placements. What placements are available are under pressure. Too many young people in foster families, in children's homes. That creates stresses, results in placement breakdown, and ultimately more placement moves for children and young people. A key priority for young people is family time, so that connection with their birth families. We see that is one of the top 3 issues for all children and young people. A lot of this is to make changes. They want to make changes to the current arrangements, or what we're seeing more of these days is that the arrangements are not being adhered to. So workforce issues are causing problems where children aren't being able to meet with parents, siblings, grandparents, and the important people in their lives. The VOIPEC's work has increased supporting young people entering into secure care, and in particular we're seeing a rising need in the number of young people needing support for care planning and increased support for young people in their exit plans and difficulty trying to actually place young people leaving some of our regional centres, including the Juvenile Justice Centre as well as Lakewood Secure Centre. Preparation and support for young people leaving care, their financial support, lack of suitable accommodation and assistance with education, training and access to other services is what we see as a priority for our advocacy work with 16+ young people. And in recent years as well, we're seeing a growing number of complaints and appeals that we wouldn't have traditionally worked with young people for. And I think these are all symptomatic of the growing pressures on services and the difficult circumstances our young people are living in. We need to see action in a few key areas. A government policy has to address the growing rates of poverty and deprivation. Children from the most deprived areas in Northern Ireland are 9 times more likely to enter care. The number of children in care continues to rise. We have provisional stats from the department that as of August this year, there are 4,134 children and young people living in care. And we know the numbers continue to go up. We have a system that's is finding it difficult to manage and support and care for the young people there today, never mind the young people that are coming tomorrow and next week. We need investment in coordinated early age and stage interventions and services that provide effective and early support into families' homes to reduce the rates of referral to child protection services and ongoing admissions to care. This spending to save will have long-term benefits, not only for the children and families now, but for our public services in the future, reducing need in later life for crisis services in mental health, addictions, homelessness services, accommodation and criminal justice. Sometimes we hear lots of talk about the cost of reform, but we don't hear enough about what the cost will be if we don't reform and transform our services. Funding of services has a direct impact on the numbers of children needing a care placement. A 2021 study in England found that for each £10 per child decrease in funding, this was associated with an extra 1.9 per 100,000 of 16 and 17-year-olds entering care the following year. Workforce pressures remain, and we have teams experiencing an over 40% vacancy rate. And I think it can be conservative there for some. We've noticed a growing number of our children and young people with no allocated social worker. 77% of the young people in our leaving and aftercare services didn't have an allocated personal advisor. Investment is needed, but a whole system approach is needed. Changing one aspect of children's services has a knock-on effect on other parts of that continuum, and we have seen that in the past. Initiatives to support young people to remain with their foster carers post-18 had unintended consequences on fostering provision and services as a whole. Managing residential services during COVID and meeting the rising demand on residential services had a detrimental impact on respite for families of children with disabilities. We have to stop tinkering around the edges and with individual components of the wider system if we want to have system transformation. There are enablers in the interim. The full potential of the Children's Services Cooperation Act should be maximised to improve the well-being of all children and young people. We need to ensure a more effective use of limited resources to secure earlier, lower cost interventions which have better outcomes for children, creative approaches to cooperation across departments, public authorities and children's services providers across all sectors. In my view, the key recommendation for the recommendation for the delivery of children's social care through a single agency is the key enabler to the implementation of the review's recommendations. The benefits to me are clear: streamlined leadership and direction, single agency strategic planning and monitoring, transparent budgeting and spending that's not in competition with health services, streamlined outcome measurements, measuring the impact on our children, young people and families, improved communication, better service and practice development and implementation. Change management could be less complicated, and our children and families would experience more consistent applications of their standards of services and better protection of their rights and entitlements. The recommendations within the review set out a series of actions to change how children and young people are supported and cared for, and the need for a Children and Families Agency to deliver that transformation. As Ray Jones, the independent reviewer, has said, there's been lots of activity, but not enough action. VOIPIC is currently working with the Department of Health, engaged in the Reform Board process and the Reimagine Children's Collective, to ensure that recommendations are delivered. But without ministerial direction and the implementation of the review's recommendation, the reform programme lacks a coherent and ambitious vision. We look forward to facilitating engagement between members of the committee and young people currently in and leaving care later this month and over the course of the remainder of the Assembly's mandate. But it's essential that members hear directly from the most powerful advocates for children and young people in care, and that's the children and young people themselves. The appeal from the independent reviewer and the young people involved in the process was clear. They said the clock is ticking and don't let us down. The clock is ticking, and it has been for the past 471 days since the report was published. And we're getting dangerously too close to letting our children and young people and families down. Thank you.
Thank you, Alicia, for that very comprehensive piece. I think it's good to hear from your perspective. We've had Ray Jones here, as you know, and we've had a number of meetings with him. So I mean, we're very clear on where we need to be going, and obviously as a committee we want to keep a very close eye on the progress of the implementation of the recommendations. Which we have been doing, and we've been getting regular reports. I think if you maybe had tuned in last week to any of the committee, we had raised some issues around the speed and some of the things around that, so hopefully we can tease some of that out today. I'm just going to have a couple of questions because I know some of my colleagues will want to cover specific areas as well. I suppose
the others not want to come in before the questions.
Right.
We had some comments each. That
Oh,
we were going to
sorry,
make.
sorry. Okay, I thought you were finished. Sorry, because go on ahead. Go on. I'm just conscious of time because we probably are running quite tight. Sorry, I thought
fairly tight. And I'm not going to repeat anything that Alicia said, but I just want to acknowledge that that very comprehensive overview has brought the children and young people into very sharp focus for today's conversation. I am the director of the Foster Network, a charity and membership organisation for foster carers, part of the Continuum of Care, and we're part of the Reimagine collective precisely because it is keeping a very sharp focus on the needs of those children who are looked after. I'm also a member of the Fostering Work Stream within the Reform Board. As a charity, we have 100% membership of foster carers and kinship foster carers across the north, and corporate and organisational membership of all the independent fostering agencies and the 5 trusts. And we also work closely with our members to amplify their views to bring about changes which will ensure every child and young person looked after has the chance to flourish. And also a lot of the comments that I will make were reflected to Professor Jones during the time of his review. So my comments are based on the consultations with them and include some notable findings as well from our forthcoming research publication on the state of the nations in foster care. All of you will know that foster care provides children with a safe and loving home when they can't live with their birth families. They give children the care, stability and nurture they need to overcome a very difficult start in life, heal from trauma and develop meaningful relationships. And good foster care is a protective factor. It promotes resilience, helps children to realise their aspirations and full potential. The increasing rate of children in care has been more rapid here than anywhere else in the last 10 years. These rates continued to increase as the cost of living costs deepened. Government here, trusts, but particularly government here, are effectively the corporate parent for these children, and our members have been disappointed that the draft programme for government, doesn't highlight children who are looked after as a named priority group as in previous programmes for government. As Alicia mentioned, we currently have 4,134 children and young people who are looked after. 83% of those are looked after in foster homes today, and that's 3,400 children in as many homes across every primary school, every community, right across Northern Ireland. In 2023, the number of children in care increased by 5% on the previous year and 35% in the last 10 years. And that hasn't been matched by fostering provision investment. Challenges in recruitment and retention of foster carers also have created a perfect storm. We have approximately 2,830 foster care families here, and in May of this year we estimated we needed a further 260 just to keep pace with demand. And figures on the 31st of March last year showed that in 2023 419 foster carers were deregistered by health and social care trusts. That's a very significant percentage of that, almost 3,000. Many reasons for their deregistration, but a significant loss, I'm sure you'll agree. We believe retention is equally as important as recruitment. But despite this, the annual uplift this year for foster carers allowances was 3%, putting Northern Ireland foster carers even further behind other countries in the UK, with whom we actually had parity for very many years. For comparison, 2 years ago, England increased allowances by 12%. Our forthcoming State of the Nations research report will provide further evidence of the challenges we need to address and why we are struggling to recruit and retain foster carers. Really concerningly, 72% of foster carers here who responded said their fostering allowances did not meet the costs of looking after the children they care for. Same question asked in England resulted in 52%. 54% undertake some form of paid work here alongside their fostering, 40% in England, Scotland and Wales. Support provided to foster carers is primarily through their supervising social workers, and really concerningly, only 78% of our foster carers said that they currently had an allocated supervising social worker, compared to 97% in England, Wales and Scotland. Many of you will have seen our report on Fostering Brighter Futures, which responded to Professor Jones's review, and that highlighted further inconsistencies across the trusts and social care systems, processes and service provision, including early intervention, high vacancy rates and turnover within social work, inconsistency in contact with social workers, and despite providing daily care 24/7, 365 for children and young people, foster carers still feel like they are not treated as a part of the team around the child, and legislative and policy change has continued to be slow. So what needs to happen?
From my perspective, something that could be done immediately is an uplift in foster care allowances that would bring us back into parity with the rest of the UK. We also need a clear, coordinated framework to ensure the findings and recommendations of the review are implemented. The implementation of the arm's length body. We have been pleased to see some progress around the introduction of fostering standards, but they were first consulted on in 2013. These also must be resourced. Implementation of the review's recommendations in relation to foster care must include plans to ensure foster carers are a valued part of the social care workforce, the development of a Northern Ireland-wide recruitment and retention strategy with skills-based learning and development framework and increased financial support through equity of fees and allowances here, and a greater emphasis on fostering in social work and professional training, as well as, very simply, inclusion of foster carers in key meetings and decisions making about children in their care, as well as a focus on early intervention as part of an evidence-informed framework of interventions to support foster carers and kinship carers in their roles. Thank you.
Thank you, Kathleen. Yeah.
Thank you. I'll try and be brief and not repeat too much, but it's safe to say that what both other presenters have said we 100% support and agree with. But actually for children, I guess our role is to protect and support children, young people and their families, and providing practical and emotional care within community settings. And we try and produce research and push for change in 3 main areas in both the UK and here in the north of Ireland. And one of the main things that I think is hugely relevant is a fair social security system as number one, and the anti-poverty piece that Alicia's already referred to. I was in the committee's meeting this morning making the same point and making that direct connection as well to the social care review process. One is that deeply connected to the other, as are all the other pieces of the pillars and the priorities within the current draft programme for government, unless we're looking at anti-poverty legislation and progress in that. These situations and these processes that we're talking about today are going to continue to be major barriers. The second thing we're looking at all the time is help for families when they need it. At the minute, early support since 2010 has been either cut or stayed at the same level, and that is very much what's driving these increased numbers of children in care in Northern Ireland. It's the highest since records began. And that's why we feel that we need to make that point again and again, that until we deal with poverty, until we deal with those things, those numbers that these ladies have already presented are just going to continue. I hope that members received in their pack our recent report, A Place to Call Home, and that was a UK-wide piece of research with one specific here as well. And that is because we're campaigning around a more supportive care system that also includes social housing for care experienced young people. We just want to emphasise again, as Alicia did, that the voice of children and young people here, we found out that essentially, over 400 days since the review, very little on the ground has changed for children and young people. It highlighted again as well the cross-cutting and systemic issues that originally initiated the calls for reform and why we're all here today. I think as a collective, we are becoming more and more clear that support for the recommendation for the formation of an arm's length body for children's services is a key enabler for all the ambitions within it. We've discovered in this process that very many bits of the hoped for changes can't be done in tiny bits. The tinkering around the edges, too much is interdependent and has to be done at the same time or in a particular sequence. That grip and vision and leadership has to be there, and at the moment it's not. There's also the limitations around resources for the bits that require extra or new resources, as Kathleen I think alluded to in particular. To potentially change this would require a decision on the ALB and the cross-executive agreement. For example, on the legislation in the Children's Services Cooperation Act, I think hopefully you'll be aware that we've also been raising questions in relation to mental health funding around this, that there are levers and tools we can use for children's services that could allow for the investment and resource that actually empower us to actually take action on the ground with the people who are interacting with children and young people services. We just think that we have to lift our eyes from the crisis mode and the discussions and the meetings and really look at the tangible things that we can do to make an impact we keep getting asked what can be the quick wins. You've heard some already today. I would say very clearly that some of the quick wins would be looking at family support and investing in the infrastructure we already have. There is a really strong infrastructure there. Looking at that from now and investing in that properly would be so crucial. We really want to see decision from the Minister on the ALB soon. From our position at Action for Children, we think until that happens, we are going to remain tinkering around the edges, and we cannot wait any longer. The children and young people in our Place to Call Home report are surviving, they're not thriving, and our ambition is to change that, and that's collectively why we're here today. Michelle.
Thank you very much. So my name is Michelle Janes. I'm the Director of Barnardo's here in Northern Ireland. I chair the Reimagine Children's Collective, and I also sit as a community and voluntary sector representative on the Strategic Reform Programme Board. I'm going to spend a couple of minutes just giving you an overview of the collective, the work that we've been involved in. So we're a coalition of 10 of the largest regional children's charities here in Northern Ireland, unified by a shared commitment to transforming children's social care. Our collective expertise spans everything from antenatal care, early years, child and youth services, family support, fostering and adoption, advocacy, and work with children affected by poverty, care and disabilities. So why did we form the collective? We recognise the independent review presents an opportunity for transformational change. Current children's social care services are not meeting families' needs, and innovative approaches are necessary to improve and transform the system. The children's sector was highly engaged throughout the review process. Many organisations consulted children, young people, parents, carers, participated in research. You conducted research, participated in workshops, met with the review panel, developed detailed consultation submissions. We feel responsible for ensuring the voices of children, young people and families are heard and acted upon. The scope of the review is vast, it's huge, and no single organisation or government department has the expertise to tackle the complexity of these challenges alone. Not one. Collaboration is essential. My colleagues have talked about, and I've talked to colleagues here already about the Children's Cooperation Act. That collaboration is essential to effectively address the challenges and bring about meaningful change. We, as a collective, are collaborating with the Department of Health through the Reset and Rebalance workstream. That's workstream 6, aimed at resetting the dynamics between the community and voluntary sector and statutory bodies. That was recommendation 47 in Ray's review. Our goal is to create a more collaborative approach to improve outcomes for children, young people and families. Our objectives about resetting are about strengthening partnerships, improving communication, securing fair representation for the voluntary and community organisations. We are also really focused on making systemic changes, including securing better funding for children's social care. In terms of rebalance, we want to shift the focus of children's social care, as colleagues have said, from crisis intervention to early family support through collaboration and resource sharing across the departments and the trusts. So the current initiatives that we're involved in, and some of you already heard this, but we've made some progress, and I think it's always really good to highlight the progress as well. So review conference. So Professor Jones recommended that an annual conference was held to track the progress of the implementation of the recommendations of the review, number 53. We're delivering this in partnership with the Department of Health on Wednesday the 27th of November. We've just gone ahead, and we hope to hear from the Health Minister, young people as the experts in this, and from Professor Jones. In terms of the Family and Children's Charter, our work has shown that children, young people and families often feel that engaging with children's social care services is frustrating and disempowering. The Reset and Rebalance workstream is supporting the co-design of a Children and Families Charter. The Charter aims to establish a social contract between children's social care services and the families who rely on them. This is an important piece of work, as this will provide something tangible based on the feedback we have received from those engaging in social care services. Our children, young people, families engaged in this review process, and they deserve to hear back what they asked for. They need to hear that actually we're going to deliver on it. The third thing we're focused on at the minute is a new funding model. The Reimagine Children's Collective is working with statutory partners to develop proposals for a new funding model for services delivered by the voluntary and community sector. This dialogue aims to raise awareness of challenges such as underinvestment, short-term contracts, job insecurity and rising costs. It also seeks to strengthen multi-agency working, moving away from a transactional relationship towards better collaboration. While the workstream is still in early stages, it's already helped build valuable relationships with statutory colleagues and explore new ways to collaborate. It's essential that the experience and the expertise of the community and voluntary sector are included and utilised in this process. Today, the committee has heard from my colleagues about the challenges facing young people, parents and foster carers in Northern Ireland in 2024. This situation is unacceptable. The review was published 16 months ago, and even before that, we were fully aware of the problems in children's social care and their damaging impact on children and families. We agree with Professor Jones that the difficulties in children's social care are systemic and endemic. To bring about positive change, we need significant transformational reform of both the structures, the culture, and how children's services are planned and delivered. In our view, the review recommendations provide a clear blueprint for how we can achieve this. As I said at the start, we recognise the scale of the challenge in reforming children's social care services. We believe it can be done. We really do. We wouldn't be here. We're putting in our own time and effort and energy. We believe it can be done with everybody working together towards shared outcomes. As a collective, we are deeply committed to improving outcomes for the children, young people and families we work with. This commitment motivates us, all of us, to work together and collaborate with others to bring about the positive and lasting change that our children in Northern Ireland deserve. Our ask of the committee is to use its scrutiny and influence to drive this change forward with urgency. Our children can't wait any longer. Thank you for listening to us.
Thank you, Michelle. Thank you all. Apologies, I was rushing on. It wasn't intentional. Look, I suppose, I mean, you've probably answered quite a lot of questions in your opening remarks individually. I think that has been extremely comprehensive. And whilst we have been looking at this very closely, and it is a focus for us, I think coming from the various perspectives, but with the same common themes, has been really, really useful today. I suppose, I mean, I just want to touch on some of your remarks, Michelle, there around the importance of the role of the community voluntary sector. So we have 4 organisations here in front of us. Each of you have an invaluable role. The level of knowledge, expertise and the insight and understanding of the issues affecting children, young people, families, and what needs to happen, I think is just, and I mean, it's not as if I've just said this for the first time today, I'm always saying it, but I just think this is a really, really clear example of how important the sector is. And I would be keen to see more around the model you're talking about, Michelle, because some of the questions I was going to ask is around access and funding. We had a debate earlier in the week in terms of access and funding for community voluntary sector in terms of mental health provision. But I know that that's something that's across the piece in terms of community voluntary sector. So I suppose without maybe, and I would like to hear a wee bit more about that, because that's about listening to what are the improvements that can happen, what does that look like, and how do we make sure from here on in that the community voluntary sector are seen as equal partners. We have all had engagements with the trade unions in terms of children's social work services and the real deepening crisis that's there, and you've alluded to it in your remarks. Very, very worrying. And there's a twin track approach to dealing with that, and that's dealing with the issues impacting on staff in social work services, but also ensuring that children aren't ending up engaged and families there as well. And that's where a lot of you come in as well. So if we're doing that, I think the funding piece is something that we really need to tackle and get right. So I suppose around that, Michelle, or anybody else, if you want to come in. And
so we've really just at the start of that journey, I had a very useful meeting with officials from the Department of Finance probably 2 or 3 weeks ago now, just asking from our experience about how different government departments do things, because we will all have experience of funding from Department of Health, Communities, Economy, Education, different ways. So we actually don't think that they need to reinvent the wheel. We actually think that there is really already in existence papers, things that have been written, policy, direction that actually needs to be rolled out across government departments. So we are looking at that, but we do want to move away from this transactional approach. So Kathleen, you will deliver 6 sessions to 4 children on a Friday night to what do the children actually need? What are the outcomes we're trying to change, and how do we go about that? And whether you get 6 children or 4 children or whatever, if we deliver positive outcomes, we start to change things. It's also about looking across. We've been talking about how you look across departments. The investment is at times duplicated in different departments, and so we need to take a really good look at that and look at where we need to put money at the right time. You're so right in what you say about we're trying really hard to prevent children coming into the system if they don't need to, and when they do, we have to give them the best. We have to give them the best. But go back to what my colleagues have said, especially what Sheena was saying. So if a child in poverty is 9 times more likely, why are we not addressing poverty?
Absolutely.
We didn't even say it in the programme for government. You know, I'm really concerned about that, because you want a quick win? Let's get brave with our poverty strategy. Let's get it out there. Let's start implementing it. So that's one of the first things. So we've still got a lot of work to do on the funding model, but I think that the bones are already there. We don't need to be reinventing wheels.
Yeah.
There are things already available that just need to be tweaked, rolled out, implemented. And I think, I've had a conversation with some of you previously about the poor implementation. We'd fund the crisis. We need to be planning now and doing things in a better, more joined up way.
No, absolutely. And I think that, even just talking around that transactional approach, for me, and I work with some of the organisations you'll be aware of from my own constituency, Bolster, Clanrye, etc., doing phenomenal work on the ground, adapting to the changing needs of what's around them, like you all do, but then being asked to fit into boxes. For me, it should be about quality, not quantity.
Yes.
And that's...
to that, maybe just, Chair, I think the one thing that's really important that Ray Jones did, and I think it's one of the reasons why I'm involved in the Reimagining, is that if you ask the question, what do we need to do for children and young people, you will get a different answer. And I think that if we're told you have to jump through this hoop and that structure and this structure, if you go right back and you underpinning principle is that what is the right thing to do for children and young people to keep them safe and to make sure that they can flourish as adults, then you will your answer for your policy and your processes will look different.
Yeah, and I think the point you make there around it, Michelle, as well, about keeping children, young people, families out of the system. For me, if we can give them empower families at the earliest stage to deal with the issues around poverty, because that's essentially what it comes from. It's about their circumstances in many cases. Now, there's always going to be cases that it's more than that. Then we're not dealing with the crises at the end of it. And that leads on just very quickly another point in terms of the need for cross-departmental working. And I just wanted to get a sense, I know you've been presented to other committees, so are you seeing an appetite for that? I'm seeing it in other areas of work. We were talking about learning disability earlier, and there is definitely I feel a shift right across the executive, but particularly around children's services. I think there's a really, really good opportunity here, and it ties in with anti-poverty and all of that. So just in terms of what you've heard so far.
Could I suppose say, in some ways, just maybe going back a wee bit, in terms of facilitating that level of cross-departmental working, the finance piece, I think, is really crucial when it comes down to what you were saying, Michelle, like the duplication even in terms of reporting and, in terms of when you get your money into this, and the reporting of outcomes and the financial costings, all those things, it kind of comes down to how the contracts are originally commissioned and who does what. And I think that's why the policy piece is really important, and even the role of the Finance Minister and the guidance that comes out of Finance Department to the other departments. And I think that was raised in the debate earlier this week, and I do think that's a really key point. But then I think it's also about we want to also move to this collaborative and collective impact approach, which means that from the start, social value and collaboration, and we see each other's values, and as both in statutory, we want to work in partnership with statutory as well as each other. But the way it's marketed, the way it's a competitive marketplace for care, it doesn't work, and we want to kind of see that transformation. And to do that, we need every department to understand that. We need them to know that if you make this a competitive procurement process, this is the outcome of that. It means that we cannot operate together. We're fighting each other for pots of money rather than thinking, how can we use this pot of money collaboratively, collectively for maximum impact in the strength, based on our strength. We know each other's strengths and assets, and when we come together, it's a really imaginative, creative, agile force. And I think you have to sort of go to that starting point to kind of get to that trajectory. And I think that starts at, in the Finance Department, but throughout across departmentally, and that is the importance as well of, within the programme for government, this process having a place there, having a very clear space in that agenda, and all the links being made. And at the minute, we hope it's going to be, but you just kind of want to make sure that it will be going forward.
Oh, that's it, and I think that we should always be outcomes focused, because what are we actually going to achieve? What is the end goal here? And if we're not looking at them, we're not doing the right things. And as you said, Sheena, when everyone's working in competition, there's levels of duplication, and I think it's better value for money for everybody, and better outcomes if we're working across and we're complementing each other, and that works as well as between statutory and community voluntary sector as well. So I have Linda.
Thank you, and can I apologise before I speak? I am going to have to leave before this is over, and I'm sorry, and I know a lot of the issues anyway, but and I appreciate all of your presentations. And I suppose just first of all, Michelle, to say I think you're right. I think we can make it better. I think we can change it, and we wouldn't be here either if we didn't think that, to be honest with you, because we have to. Because my feeling is, if we don't, this is our HIA of the future, where we've let the children down again. It's different. It's not intentional abuse, but it's abusing them nevertheless, because if we're not doing the best for them, then we're causing them harm. So I do think that's an important point to make, just in terms of, because the work you have done and the report you have come up with is really, really good, and it's really easy for anybody to understand, which is helpful, I have to say. But in terms of then what you have done and making that real, what is in place or what needs to be in place in terms of the department, and I'm talking about health at this moment in time as the lead department, but I agree every single department plays its part in this, and no department should be trying to duck that, but health is the lead in terms of engaging the Reimagine collective, because you have the answers, and it's about engaging you and making sure that the solutions that we're coming up with will work, and that we are all working together. You just alluded to it, Sheena, around that, that collaboration is right across the piece. So what could be in place to make sure that regular, meaningful engagement that actually ensures that the right decisions are being made, but that they're also being implemented? That you're having that enough engagement to say, this is the things we should do. Here, it's not happening, or it's not happening quick enough, or how could we do it quicker?
Okay, that's a really good question, Linda. So we do work, so the Reimagine Collective, we joined the Workstream 6, which is a jointly chaired workstream, Reset and Rebalance, with the Department of Health. So I co-chair that, so there is regular, a lot of regular engagement. I think some of our challenges is that we are used to getting on doing. We don't have time to wait, because we have the children and families in front of us all the time. We have young people who want answers. We need foster carers who need their allowances lifted. So we want to move really quickly. The bit is that there's bureaucracy that the system that is inbuilt in some of the systems that we can't do anything about. So, for example, when I met some of you a few weeks ago, we talked about the conference, not being able to set a date, whatever. So we just are saying, look, that we need to move on this. So we are bound by some of the bureaucracy and some of the systems, but actually these systems need to change. We are trying to move things on in a system that is broken, and I don't just mean that in terms of that in children's social care. There's bureaucracy within the wider system of departments that actually make things really slow. You've got to have another paper, and you've got to have... We need to actually just say, do you know, trust us. We all work for charities. We can't spend a penny that doesn't belong to us. If we can't spend it, we give it back. Trust us, we know what we're doing. Allow us to move ahead with some of these. There's some really are genuinely some really quick wins. We have an infrastructure in terms of family support hubs in Northern Ireland. It's fantastic. It's got an evidence base. Sky have reviewed it. It does early intervention really well. We don't need to look for something else just now. We could just invest a bit better in that consistently across Northern Ireland, not a wee bit there and a wee bit there, consistently. The foster care allowance one is a really easy one. We want our foster carers to feel as valued as any other foster care across the UK. We need to increase their payments in order to be able to... I don't know any foster carers that have come into this for the funding, but we have 4,134 children in care at this moment in time, and we need to do something about it. So there are quick wins. So we are feeding that directly back to the department all of the time. I do feel that they're bound by a bureaucracy that we can't change, even though I'm saying we're just going to do this now. But you can see that that's a way of working that's ingrained. I can't change that. But actually, I think one of the things that hopefully this committee can do is just in terms of the scrutiny about how we need to be able to be trusted as equal partners. We can find solutions quickly. One of the barriers is about the funding of it. I know that there are really motivated, creative, solution-focused people working with us from the trusts and the departments who really also do want to affect these, but their bit is they don't have any money. I sat in a room where I saw colleagues were just so, because they were saying we want to do what Kathleen has suggested, but it was we just have to wait and see if the money comes. We'll write a business case and we'll wait.
I think we've provided a lot of evidence. I mean, we've provided a lot of evidence today. The concerning thing is that, and we have that opportunity, I think, directly to share that. There are some very innovative ideas around in terms of how you could actually reform the looked after system generally, but we need to be clear that that's being heard. We have been consulted on multiple times. Children and young people have been consulted on multiple times. We appreciate the importance of advocacy and consultation, but we're going to continue to say the same things. So we need clarity of vision. We need clarity of priority. We need clarity that children and young people are going to be absolutely at the heart of information and resourcing. And we've provided all of that evidence. And some of the quick wins, I did mention uplift in foster care allowances. I do totally appreciate that doesn't come out of thin air, but 419 left the service last year out of just around 3,000. That's 12.5% attrition. So if I'm back here next year and it's another 12.5%, then I will have provided you and the department with that evidence, and there's nothing to indicate to me currently that trajectory is going to change because there is no investment. So all the information's been provided. We need to look to put some resource in to those areas that really will make a difference for children and young people. If you lose 400 more foster carers this year, then next year we'll be hitting 5,000 children and young people who are looked after, and and you're looking at, as you've just said, a long-term tragedy. We absolutely need action now.
Those answers are both really helpful, and I would like to see that the evidence around the foster carers that left, just to look at, because I know some of it will be financial, but I also know from some of the cases coming through my own door that some of it is not getting support, and actually quite the opposite, almost being threatened and put under real stress from social services, from the trusts, from social workers. And that is not to say, it's no slight on social workers. They are under extreme pressure. I understand that. But I have had foster carers come to me who are at breaking point. Now, they have taken children out of homes that are at breaking point, and now they are at breaking point. So there is a real issue there, and I think we do need to address it. But the answers around how things could be done, and that probably is something we could look at as a committee, how things could be done differently. You know, where is the bureaucracy that could potentially be overcome? All of those things, I definitely are things that we can look at as a committee, and really appreciate you coming here today and giving us that information. Can I just put on the record, because it came up at the meeting, and it is something I feel strongly about, and I want it on the record, that our minister, our department, should never outsource, should never privatise children's services, and particularly those looked after children and children's homes. So that was something that was made clear to us the day that we were at the meeting. But to me, it is something I'm passionate about. We should never be in that position. Children will become a commodity.
Thank you, Linda. Just very quickly, because I might have missed it, Kathleen, when you're talking about the numbers of foster carers that have left, what is the, in terms of new foster carers coming in, just to kind of get a sense of, and sorry, I know others are waiting, I just want to ask that question or it'll go out of my head.
So the reason I quoted that figure, because last year when the figures were published, the children's social care stats, that was the first time I'd ever seen it, because how we gather our data is very different to elsewhere, and that's partly because we don't have the implementation of standards here that would require us to collect some of that data. So in terms of the numbers coming in, it's not that clear how many are coming in. Individual trusts could tell you how many they are recruiting, as could the individual independent fostering providers. I mean, we've got 2 of them here in Action for Children and Bernardo's, but recruitment isn't going to address that level of attrition.
Oh, no, absolutely, and it was just to try and get
so the numbers that are coming into the service are much less than the number that we know has left. I can get you that figure and provide it for you.
We can even ask for per trust. To kind of get a sense. But I had a meeting with the Southern Trust last Friday, and we talked about it. I was meeting with Colin McCaffrey on Children's Services, and I had just talked about, because I know I've done engagement in the past with foster and social workers and that, who are obviously trying to encourage recruitment. So just was interested in that. But thank you. Sorry, Diane.
Oh yeah, thank you. So I met you a few weeks ago, so I'm not going to go over ground and so on. One of the saddest things that I actually heard today, and forgive me, I can't remember who said it, but anyway, just was that, and I just noted it down, that despite the review and despite the whatever number of days and weeks it has been since the review, very little had changed on the ground. And I must say, we have had a number of briefings from officials from the department who are working on the review, but I'm not sure that any of us really around the table are clear what has changed on the ground either, out of all of those briefings. I'm glad to see some other people nodding their head as well. So I kind of like to do things rather than sit and talk about things. So you have your conference coming up. Was the department dragged to the conference, or is the department co-working with you on the conference? That's just the first one. It's just an aside almost. The second one is, within the next 6 months, what are the 6 things that you want to see that would change on the ground and make life better for young people and children and those involved in delivering children's services? If we could get 6 quick wins, what are those 6 quick wins that you could have in 6 months and that would make life significantly better? Because we as a committee can then ask about those quick wins. And where are they? And why can we not get on ahead? I understand your view, and I've spoken to you about your view about an arm's length body, but quite frankly, that is a legislative issue. That'll be a long term issue, and we can't wait for that. We need to do things in the meantime.
Yeah, and I'll start. Sheena, do you want to?
Just on that point you made around a legislative, I think there is a way that you could have a shadow ALB set up without the legislative. There's sort of a sequence that even Professor Jones sort of suggested for this that wouldn't require that, and that actually would be essential to kind of navigating the current sort of disparate response that's kind of in pieces all around in different spaces and lots of meetings in different trust areas, etc. So I'll just maybe highlight that, and I'm not trying to be, but just that there are probably ways this could be done if there was an appointment of a clear leader with that specific responsibility of coordination across the region, where that wouldn't necessarily require legislation. I think, is that inaccurate? Yeah.
So I'll go back now to your first question about the department, have been involved in the agreements around the conference. I think our challenge was just agreeing a date, because there's other things I think need to happen. We're waiting for an announcement from the Minister on his take on it, and I do understand that requires some cross-executive conversations and decision making. But no, the department are supporting us, and they're actually providing some of the funding for the conference, which is really helpful. Quick wins in terms, I suppose we have some priority areas and in terms of solutions. The first one, you'll have heard it all already in terms of listening to children, young people and families. We need to prioritise their voices. And that's where you're seeing we're developing the Children and Family Charter. So, I'm quite happy if you come back and say, well, where's that getting to? Because that's a piece of work that is being developed with our colleagues in the statutory sector. We've been having some workshops to look at that. The bit about the invest in early, renewing the focus on investment in early intervention and prevention within our communities, including expanding Sure Start. The Sure Start expansion, in the consultation responses to the review report, 83% of those that responded agreed that Sure Start should be expanded to reach all children aged 0 to 3 and their families outside the current catchment areas. Imagine how fantastic it would be if we were able to have a baseline where all of our, is equal to all of our children and families. Sure Start currently operates in the most deprived wards across Northern Ireland, but the bit is that actually our housing situation is such that means that families are living outside those wards and can't access this current provision. So if 83% of people who responded to the consultation agree that we should be expanding it, let's look at that. Let's look at the progress that could make, because we know that the outcomes for children who've been through those programmes are really positive. So we could look at that. The cross-sector collaboration, we want to foster collective action for transformational change. So we're seeing some of that starting in terms of our role on the reform board and some of the work streams. But, in terms of how that translates into actual action, that's a challenge one. And go back to what Linda said, we feel very strongly there should be no profit in children's social care. And I think some of my colleagues would share concerns that potentially is happening already here in Northern Ireland. And then the accountability, and I know you're working really hard and have said that this is one of your priority areas, but we really need to develop ways to hold the system accountable. So in terms of, Kathleen has talked about, imagine not knowing how many people have applied to be foster carers in Northern Ireland. We should be able to do that at the touch of a button. There's huge issues around data collection region-wide. We need to monitor the systems to find out what's working for who and ensure we don't find ourselves in this situation again. But also go back those to my bits, the Foster Care Alliance, the Family Support Hubs, the Sure Start bit, the advocacy services. Those are things that we know will affect long-term change in terms of our children's outcomes. So
Can I also give you a couple of examples of things that could be done really that don't cost very much money? There is money being invested in recruitment of foster carers. I think there should be a region-wide approach to that. We should have a campaign. We run Foster Care Fortnight every year in May, and that is effectively the Northern Ireland campaign on recruitment of foster carers. We need something in addition to that. We run that in a shoestring. And we do it really effectively. And so a small amount of investment could make a massive amount of difference. But also that process needs to be relational and strengths-based. It needs to ensure that inquirers and applicants have access to foster carers, and it needs to have people at the other end who can actually do the assessment. So we need to ensure that when people are being encouraged to apply for fostering, that there are people who can assess what they're doing. We also need to make sure that our delegated authority guidance that is issued by the department on an ongoing basis is up to scratch, and that it meets the needs of foster carers. The Review of Children's Services in England, we recommended that foster carers should have delegated authority in which they can agree to a child getting their hair cut, going on a school trip, very simple things that aid everybody's life, that they should be able to do that as a matter of default unless there's a reason why not. So instead of having to have social workers perhaps tied up in discussing issues around, well, what does delegated authority mean for this individual child, that could release some very much needed time for children and young people to actually spend, social workers doing other things. And I also think that in terms of allowances, we do need to have some kind of clearly defined understanding of how they come about. We need to have an opportunity for foster carers to be able to feed into that. So we need a process that's around ensuring that annually, all of us in terms of our employment or other areas are usually, there's a union or there's a membership organisation, or there's a group of people who are asked about what's needed going forward, and there needs to be a clearly defined, transparent process around those things. None of those require legislation. None of them require a great deal of investment. Those are things that could be done really quite quickly, and I think measures to address the issue around social work and ensure that we have multidisciplinary teams working with children and families. There are things that social workers are being asked to do that could be easily done by other people, and there are a number of very practical things. I could go on, but I won't. I'm conscious of your time. But
Can I just ask one last question, Chair? Have you any data on the disparity between services in different trusts for children and young people? I'm thinking particularly over the last number of weeks, I've had a lot of conversations around the disparity in trusts in terms of respite services that are provided, and anything like that would be very, very helpful. Because I do think that there is a very big discrepancy in what is provided from one trust to another, often 5 minutes apart if you live in a different trust area.
There is a bit of a postcode lottery. We've just done a document called Out-of-Pocket Fare Fees for Foster Carers, and we did FOIs across the whole of the UK. And so we gathered data in terms of the differences in terms of fee payments for foster carers as opposed to allowances, and we could see the differences. So there are really substantial differences in how that's done. 2 trusts didn't respond, but what we know is that some trusts are doing that in a more systematic way, and so their foster carers will experience perhaps more sense of continuity, and maybe that makes them feel more valued. And others didn't produce that information, whether or not they don't gather that data. But certainly what we're seeing is, what we know is that if a proper fee and allowance structure for foster carers, we have the same allowances right across all 5 trusts. We're the only part of the UK that does that. So allowances here across all 5 trusts are exactly the same. But what we have is in terms of any additional remuneration in respect of children with additional needs, or where there's respite, that is completely ad hoc in many respects. It's certainly something that's being looked at within the fostering work stream. So one of the things you asked was around some of the things that have been done that have been helpful. So we have been really pleased, because every time I go to these meetings I talk about we need our standards, we need our regulations, and we are moving further towards that, but we need them to move at pace, and we need resourcing to implement them as well. And there's differential
consistency
absolutely
across all of the trusts to do that,
because
and they don't get that.
We see variation across the trusts and how they're interpreting and implementing regional policies and procedures. So for example, for young people leaving care, depending on where they will live, there's different support available to young people. Particularly we're seeing greater disparity for young people wanting to go into higher education. So some will get better support in other trusts. When they are moving out of care, setting up home allowances can vary. So it's policy, it's structure, where you can see differences, which is why that notion of a single agency doesn't need to be an ALB. But that's why I think that's a really good recommendation and such an enabler, because it will essentially, you have that strategic one line of leadership that should ensure consistency.
Okay, Nuala?
Thank you very much for coming here today. You know, children's services, particularly under social care, is a priority for us as a committee. I'm not sure if the chair's mentioned, but we do have a committee motion next week that we're bringing forward to the Assembly because we wanted to ensure that we all work together and bringing this issue to the floor constantly because it needs to be a priority. Hopefully we'll get some kind of answers from the Minister on some of the outstanding recommendations then. So hopefully you can tune in. And there's some things that you said that a number of you that I want to touch upon. And first, Alicia, you actually said something around children leaving care and the disparity, but you made a comment and said, oh, there's too many under 18 that are actually leaving care. So I wonder if you can kind of explain that a little bit more, because that's just really frightening to hear. Because I assume that child under 18 is not going back into the care of their family. Do you mean they're leaving the care Well, system? I suppose we're seeing a range of things happening. Young people have reported to us and have given us examples of when they felt that they were being encouraged to move on or not being able to, for example, avail of, for young people in foster care, not being able to avail of the GEM scheme. And that's really about protecting the foster places for younger children. So we are seeing more 16 and 17-year-olds. We have a range of supported accommodation projects available across Northern Ireland. There was some of those places are for 16 and 17-year-olds, but the majority were for 18 plus. We're seeing those projects are primarily being filled by 16 and 17-year-olds. They're becoming quasi-children's homes because younger children, traditionally it would, residential care, would have been a provision for children over the age of 12. So we're seeing more and more younger children, 8, 9 and 10-year-olds in residential care. So it just all has a knock-on effect. As I mentioned earlier, you try to make reform or make changes in one part of the system, and there are knock-on effects unless you're looking at it whole in the round.
I assume that means if they're under 18 that the trust or the department is feeling their statutory obligations regarding that young person when they're under their care, and is that the case as well when it comes to the access to support post 18? Are they meeting their minimum statutory obligations even?
Well, we're finding that, I think I referred to earlier, about 3/4 of the young people that we're working with 16 plus don't have a personal advisor, and that is a requirement. We do find that there will be measures made to ensure that young people have social work support if they're not living in a care placement. We are finding maybe more young people returning home to parents, but maybe feeling that return isn't being well supported, and sometimes the issues that were in the family haven't necessarily been resolved. So we're seeing kind of older teenagers maybe moving quite a lot around multiple placements, going home, coming back in to residential care or to some of the other supported accommodation provisions.
I think that's something we can certainly in our speeches next week bring to the attention of the Minister. And just in general, we do get regular written briefings from the department regarding an update on the recommendations, and I assume that you don't get these briefings and these updates, but within one of the briefings it was highlighted to us that a number of the recommendations were rejected but not highlighted which ones. So are you aware of which ones are rejected? It was also highlighted that on the 34 accepted recommendations that 14 will require additional funding to progress, which makes me think that there are 20 that they had the funding in order to progress, maybe not to progress to completion, but to progress better than what they are now after 400 days. Is there a feeling or a view regarding all of the work streams? And just to be perfectly honest, very critical of not the people within the work streams, but the fact that even the work streams were set up to deal with this rather than just implement the actions in collaboration with the sector. But I just want to get a little bit sense of, do you feel the pace of the work streams is kind of good enough, and do you feel that sometimes it's just it's another additional layer to bureaucracy? Because that's certainly the feeling that we're getting, because the independent review was the review, the recommendations are the actions. So I recognise that if I'm putting you in a difficult position, because I know your position's on the various work streams, but you're the experts that work with the young people, you know, and I'm sure the young people themselves want to know, where are we with each of these? Have they even been told? Do they get an insight into the department in these work streams as to where these recommendations are?
That's what the conference will do in terms of ensure, because we always said we had to feed back to the children and young people and the families that contributed to that. We had hoped to do it earlier in the year, but it just wasn't possible in terms of the information and the progress coming through. I suppose, you know, I'm a bit worried we might get stuck in more and more analysis, as you said, in like another process rather than implementing the actions. I think we are aware of some of the information, but I wouldn't have the detail that you've just given there in relation to this being rejected, because we're waiting for the announcement from the Minister as to his position on the review and its implementation, really.
Well, he has a position on... They have a position on a number of them, because they've said that there's 3 closed. We dispute whether they're actually closed, and there's some that have been rejected. So there's clearly a view there. So we will be bringing that up to him next week, for sure.
Just in terms of your question around young people and children, you know, I think the Place to Call Home report details, you know, the narrative from them themselves of my situation has not changed, is not changing, and actually a lot of the ones we're speaking to are saying, you know, they want to raise their voice because they feel like they want to try and do something for those coming after them, because they kind of have resigned themselves at the moment. And that was really quite hard to listen to, when I suppose we are putting in a lot of energy and we have hope and aspirations for change for them, for in the now. But that sense of procrastination, or like delay, is quite frustrating when you're a service provider in the middle of that, and you know, all the engagement that even we're asking from our staff on these issues for feedback, and they're in this system and they're feeling the brokenness of it. It is very difficult to kind of walk that sort of journey together, and I think Alicia was saying that too, in terms of the feedback, you know, that they were saying the clock's ticking, and that was 400 days ago, and that's quite hard to work with constantly, that tension.
And I think, you know, in terms of the progress of work streams, I mean, one of my observations would be, whilst they're waiting on that strategic direction and decision making around which recommendations are in, what I have noticed though is they are doing their best to get a good understanding of the data that tells them more about the lives of children, what's happening in families now, and trying to predict what might be the demand on services and the needs of individual children and families. But their hands are tied when it's trying to get good data and good data collection systems, and they're having to go to individual trusts and individual teams and trying to pull together the necessary information. And you know, we need better data collection and monitoring going forward. And I know one of the recommendations that was discounted from the review was, I think there was recommendations around not using the new Encompass system for children's social care, because that was deemed to be a very kind of health focus. I know that has been rejected, but there still has been a delay in implementing that system within children's services. So it's going to be a long time before we will have good data and have a good understanding of children and young people and families and who they are in Northern Ireland.
I think the data that we do have is alarming. When the review started in February 22, there was 3,500 children in care. When the review was published, there was 3,800 children in care. That was in June 2023. And then in August, 4,134 children. So that's, I suppose, if that's not evidence of our need to move quicker and implement the recommendations, then what is? We don't need any, you know, yes, we do need systems and processes long term, but actually there are actions there that could be moved on.
Yeah. I also think it's about that early intervention stuff. So, you know, so for example, we have a service called Step Up, Step Down, which is in South Eastern Trust, which has proven to be extremely effective at keeping children safer at home with their families. And it's understanding how that might actually get rolled out, if you like. It's really, really unclear, in terms of a pathway. I have no particular vested interest in it. I mean, obviously, we evolved the programme, but it is a very highly effective programme that could be very beneficial. And, that is, again, another thing that could be done really, really quite straightforwardly and moved forward. And what we know within South Eastern Trust over the last 5 or 6 years is that has kept about 260 children at home safely with parents. Now, if you roll that out across the rest of the 5 trusts, the other 4 trusts here, then that could make a very substantial impact in terms of the numbers of children coming into the care system, but also the families who are at home who are being supported. And the cost of that service in South Eastern Trust is minuscule in comparison to the impact that it has, and certainly in comparison to how much it would cost to keep another 250 children in a trust with the foster care or with residential care provision. So there are things that it's unclear how you might then push to have those progressed further. So there's a lack of a clear pathway. But I think, to be fair as well, I think it has been an exercise in ensuring that people's voices are being heard, and there is an opportunity for that, but there is still, it's not completely clear, even though I'm on several of the groups, what's going to happen. And a lot of what we hear, and I feel sorry for our colleagues from the statutory agencies, because they're constantly having to say, well, yes, that would happen, but as Alicia mentioned earlier on, workforce and financial considerations means we cannot progress this. And if that is actually the case, that we do not have those resources, then what we need to be stating very clearly is what we do have the resources to do, because those children's needs are not going to disappear. So as we continue to advocate for a whole range of services, if a decision somewhere is being taken that actually we can't do that, then I would much rather that someone actually said, well, look, we can't prioritise that, but we're going to make really sure that we're going to do it here. We are aware that not all statutory provisions are being met, because if you've got 40% of your social work team there, then there's only so much you can do. So what can you do with that? Move upstream, invest earlier, much cheaper, using resources within the community, and keep maybe 1,250 children, young people out of care.
That's perfect in terms of, like, it's just right, the message that needs to be given to the department is, what can you do? Not always, we can't do this and we can't do that. And to be clear, and I'm sure we did discuss it last week, they told us that funding, additional resource, had been put into the work streams. Are you seeing that funding through to the sector at all? Because then I think that that was very limited in terms of the information given us, but just said additional funding had been put into the work streams.
Does that mean put in to facilitate the sort of organisation and administration of the work streams, or to deliver the services that the recommendation?
If you don't, assume if you would know if you'd had additional resources to your own organisation.
In terms of potentially, it is the administration of the work streams is where there has been investment. What we are calling for is investment earlier in the system in order, because all activities happen. It's that bit about, well, what a difference is it actually making to children, young people and families on the ground? What's the difference it's making? So we can, is that the right investment in the right place? Because we need to shift, get in there early. Yeah.
Look, I would ask more questions, but I know I don't want to keep you. And I do look forward to engaging with the young people themselves as well later this month, I think, isn't it?
Yeah.
Thank
you. Danny.
Thank you. A lot of my questions have been answered, but I've just a couple of further ones. Just following on from what Nuala said about children leaving at 16, and you're saying that they go into supported living schemes. Is that largely by choice? Is it a matter of necessity, or?
It's probably both, really, but I suppose we have supported young people through our advocacy service who, for example, would have preferred to stay on with their foster carers post 18, and that wasn't enabled. We are, yes, we're probably seeing some young people maybe voting with their feet. Some of our maybe have have been having a difficult time in residential care, and the supported accommodation, those projects were there primarily, I have to say, for 18 plus as a way of a kind of a step down model where young people would have a little more independence, but also supported to develop skills, budgeting, cooking, and really to as a stepping stone on to independent living. So what we're saying is those places are being filled with those younger children at 16 and 17, and so then at 18, then they're having to move on to independent living, for example, because it's reduced supported projects. But we're also seeing there are some young people who are being, particularly young people who are maybe coming into the system at an older age, at 16 and 17, are not being placed in residential care and are going to other provisions. There are a limited number of places in those supported accommodation projects for 16 and 17-year-old young homeless. But what we also know as well, that there are young people being placed in completely inappropriate accommodation, in hotel accommodation and B&Bs and the like. So that unregulated
no support there at all for them?
Well, particularly for those children under 18, there is an onus to put in better support around those children and young people. I can't say that that's absolutely the case for every child or young person that requires it.
That's concerning to hear. Do you consider those to be safe environments for young people?
That's why I'm saying there are particular provisions and support and direct from social work staff if those placements are if there's any concerns around those placements. There will be additional through the social work staff, but also through some support services. But my argument would be they shouldn't have to be placed in those environments at all.
That maybe leads me on to the next question, something that Linda raised just about commodification of children. You'd alluded to children, people profiting over children's support services. What does this relate to? Is that specifically that model that you were talking about?
No, so there was Linda arranged it, or raised it. One of the recommendations coming out of the review is that there wouldn't be privatisation of children's services.
It was suggested that this might already be happening. Can you give an example of that?
Well, we know that particularly over the last year or two, there have been a number of private or independent providers within residential care. And I suppose it's a range, and it's kind of what we need to get a better understanding is the generic term around independent and where are charitable organisations and what are for profit.
Could I just come in there briefly? I suppose, again, this report I was referring to was looking at the whole UK picture, and even Ray Jones, his context, obviously social work in England. In England, children's social care does have private residentials, private enterprise in care, and it's now a very difficult and huge issue that is leading to very difficult sort of consequences for people's protection, and ultimately those places are for profit, and that's I think what Linda was talking about, and I suppose that warning was very clear in the review, and I suppose we're just raising the alarm that unless there is very specific and intentional action in Northern Ireland, that we could potentially go down the same way because of the levels of demand. Business enterprises would see that as an opportunity potentially if it's not something that's got a keen eye looking over it, watching over it. So I think that's I'm happy to send a wee bit more information from the English context if that's helpful.
Although it does for respite care, we have had for children's respite care, we have had private providers.
But this is residential you're talking about.
Yeah, but I think it's across care more widely. I think generally you can see that there is a business model that would be happy to step into that space, but we would say that when care becomes a commodity, people's care outcomes generally go downwards. That's certainly the case in England. There's lots of evidence, and it's also a very there's lots of evidence that it's not even cost effective in the long run in that way. So I'd be happy to send a bit more information about it if it's useful.
Last quick question, Chair. Just you mentioned the I think it was 490 deregistered carers. 419, sorry. Over what period was that, and what was the main driver of deregistration?
There'll be a whole range of reasons why people might step down. Sometimes because people, I think, post-pandemic, perhaps find themselves in a situation where they maybe weren't able to look after children. But the reasons why a foster care are deregistered are usually complex. They have to go back to panel. There's a whole range of different reasons why that might happen. And when I say deregistration, it's a bit of a misnomer because foster carers are not actually technically registered because we don't have a register for them. So they go to panel and they're approved. So when we're talking about that, we mean approved for foster carers whose approval has been removed for whatever reason. And sometimes that's a proactive choice. So for example, I got a letter from a foster carer last week that basically said to me and outlined their reasons that because they felt they had been poorly treated and they weren't felt like they were valued, that they had decided to resign immediately, forthwith, as they said, from the fostering service. So some people, as Alicia said, vote with their feet. Some people, it may be because they've just found themselves sort of aged out. But certainly that was the first time I'd seen that statistic. So I'm looking forward to the review or the stats coming out later on this month to see if that continues to be the case and over what period, because that for me was a baseline. Last year, it was the first time. So if we have that again this year, I think it'll be interesting. But there was one thing I think might be helpful to clarify. Just when children and young people hit the age of 18, their care order falls away. And so they aren't then an adult. So then they become subject to our Go on the Extra Mile scheme, what we call the GEM scheme. And there are different payments. And so if you're a foster care and you're approved to look after children and young people, you are paid your allowances in respect of that child up to the age of 18. And that changes at 18. And Alicia had mentioned earlier that there is then, given more children are coming into the system, younger and younger, then the foster carers are then asked, will you have a space, if you like? This young person is now 18, they're an adult. In a way, can we release that space? That's something that we would have seen in terms of trends in England for a very long time, that foster carers become no longer foster care effectively. I mean, in England you have staying put, you have similar arrangements in the other 3 countries, but there is a differential in terms of the allowances in respect of that young person. And I think that that's a trend that we really want to watch, because it's certainly something that is a very substantial part of the care system in England. That seems to be emerging here because of the volume of children who need looked after.
Again, could I put in a little bit from, again, this research we just did, that foster parents we were seeing and hearing from were saying that pressure, the support that at 18, to find alternative accommodation for their foster, the foster placement with them was driving them to do, using huge amounts of their pension to find an apartment nearby so they could still continue in their support role and know that the investment that they'd made in providing a safe and stable home for that child who was now a young adult wouldn't be lost, and because they had no hope that the system would do that, if that makes sense. There was cases of buying a caravan to put in their driveway so that the foster child could move in there, so they, so that because they felt the pressure to make a space in their home for another child, which it shows the kind of caliber of the people and offering this type of care. But it shouldn't be like that, and I think that's also the real big point here about housing and accommodation, and specifically for care experienced adults at that point of need is something that we're definitely wanting to highlight more and more in the wider housing pressures that we're facing. But it does impact, like they're getting sent to unsafe
and if you think about it, I mean, I have 4 children of my own. When they all hit 18, most of them hit 18 in the middle of a school year. And if young people are, continuing education or studying, that's a huge trauma. And the anticipation of that, if then that's happening at 16, is just how do you study? How do you focus? How do you have those aspirations? So we really need to make sure that that's not going to go the way that it has gone in other countries and really increase.
Okay. Well, thank you all. I think, the discussion has been so valuable, and I think for us to get even more information on this issue, it's definitely helping us then in where we go next and what we do. So, and I hope that you get the sense of how important this is for us as a committee and how we really want to see this progressed as quickly as possible with a very outcomes focused approach. So we really do appreciate you all coming in, and we know that many of you keep us informed as well on any research or documents that you have, so that's also very much appreciated, so thank you. And I'm sure we'll have further engagement as we go on.
Thanks
All
very
right,
much.
thanks a million.
Thank you. Thank you.
Okay, members, there's
Apologies, Chair.
no problem, that's grand. I know we're well over time.
I have to go. We remain.
Okay, does anyone else need to go before we go on? Thank you. Just as long as we have quorum, we need five.
Fine.
And we need 5. Okay, so for the SORs, we need to make sure we've 5. So if anybody needs to go, they can let me know now. And we still have 2 online, 3. So are you okay, Orly, or do you need to go? Are you okay?
Sorry.
No, I think we still have enough
It's
anyway,
just
so I'll try.
car issues today.
So I'll just move on. There was just 2 points I wanted to raise, I think. Coming out of that was, firstly, if we could ask the department for the figures, those kind of attrition rates in terms of foster care. So if we could get per trust, even for the last year or 2 or whatever, but I don't know how many have left foster care and how many are recruited year on year in each trust area. I think the reason I wanted it is for each trust area is because I'm conscious that Kathleen said that there's different it's inconsistent in terms of what fees and things. There's disparities is the word I'm looking for. And I would like to see if that's maybe having an impact as well. I know it's not about money, but if they're not getting the right support, then that will have an impact. And the other, there was another one I was going to raise.
About the commissioning by private companies.
So I was going to ask the question of the department in terms of what level of commissioning they do in terms of private companies for residential care and respite care.
And respite. We know that they, remember, we raised questions about Rainbow Lodge.
Yeah.
And they withdrew the third party.
Because it is very concerning.
Yeah.
It is very concerning. So are members happy enough with those proposals?
See, just on Nuala's point as well around the additional funding
Mm-hmm.
that we're talking about going into the work streams, because the panel didn't really seem to. It would just be helpful to maybe get a wee bit of clarity on what that
is,
funding
what's it
was and
used
where
for.
it went.
Yeah, and how much it was. Yeah, no, that's fair enough. Thank you for that earlier. Okay, then members, item number 7 is the SR 2024-162, the Recovery of Health Service Charges Amounts Amendment number 2 Regulations Northern Ireland 2024. If I could refer you to the papers at tab 7, page 253 of your pack. This statutory rule increases charges in respect of injuries which occur on or after the 1st of October 2024 as set out in the rule. The rule is subject to negative procedure. The committee considered the SL1 at its meeting on the 12th of September and we were content with the merits of the policy proposal. The examiner of statutory rules has not yet reported on the technical aspects of the SR. Therefore, members will be agreeing to the SR subject to the examiner's report. Our members are content with the SR. So members agree that the Committee for Health has considered SR 2024-162, the Recovery of Health Service Charges Amounts Amendment number 2 Regulations Northern Ireland 2024, and subject to the examiner of statutory rules report has no objection to the rule. Thank you. Item number 8 then is the draft the Human Medicines Amendments relating to Naloxone and Transfer of Functions Regulations 2024. If I could refer you to page 264 of your pack. The SI amends the Human Medicine Regulations to increase the number of services, professionals or organisations that can supply Naloxone without a prescription or a written instruction, and will remove remaining references in the regulations to the now dissolved Public Health England and Health and Social Care Board. This SI is subject to draft affirmative procedure and may not be made until it is affirmed by a resolution of the House of Parliament and the Assembly. A plenary debate is expected to take place on the 14th of October. If we could just remind members that the committee considered the proposal for this SI at its meeting on the 12th of September and was content with the policy merit of the proposal and agreed that the department with the SI.
Just a small question on it, Chair, and Danny maybe will help me out with this. Is this a drug that has to be administered by injection?
Can be injection, and there's a nasal version as well.
Because I'm just wondering, it sort of says, it increases the number of people who can supply it, but I'd be worried about administering it,
I think that's probably what, because when we
would
had
be covered
officials
by,
in,
would it be trained?
Yes.
Anybody that's supplied with it, would it be trained to administer it? But I'm reassured if it's just a nasal thing, there maybe not be a lot of damage you could do to somebody.
There's
with.
two different versions. There is a needle, and it's like a pen, an EpiPen almost, a version of it that you can give.
But the training will be provided, Alan. They were saying the other week, for anyone that's going to be administering it, they're signing up to the scheme. Then it's the training is part and parcel of.
Legislation, you should think. I mean, I'm only been pedantic, but you think the legislation would say that.
Yeah. Yeah, well, I suppose I mean, we did have the discussion because those were some of the questions raised when the officials were here, because obviously it's a life-saving drug, and we were saying about just how actually, sadly, how more common it is that it actually needs to be used.
It does seem to save lives. I mean,
yeah,
you've seen
absolutely.
Sadly
Sadly
enough,
enough,
documentaries about it and stuff.
So are you happy enough with that,
Yeah,
Alan? Yeah. No, that's okay. So if our members content with the SI, yeah. So members agreed formally that the Committee for Health has considered draft SI, the Human Medicines amendments relating to Naloxone and transfers of functions, regulations 2024, and recommends that it be approved by the Assembly. Thank you. Item number 9 then is the a written briefing from the Department on the departmental responsibilities for childcare, including children with additional needs. And the written briefing is at page 2 of your table papers and includes a summary of the relevant roles and responsibilities of the Department and the Trust in relation to childcare, with a particular focus on children with additional needs. I think it was actually Linda had raised this question at a previous meeting. So our members, have anyone any comments on it, or are we happy with to note? Yep. Okay, thank you. Item number 10 then is the Department of Health's draft hospital reconfiguration, and we will have received the papers in relation to this, and the Minister made a statement to the Assembly earlier this week. The draft reconfiguration framework is at page 285 of your pack. It's titled Hospitals Creating a Network for Better Outcomes. Do members have any comments at this stage? You know, obviously the public consultation is now open. No. Okay, thank you. Item number 11 then is correspondence. If I could refer members to your correspondence list at tab 11.1 at page 413 of your pack, and then the correspondence is individually listed from page 414. Members, if I could just refer you to the response at page 422 regarding the CARES Fund and the future of Sure Start in Uri. These were issues I'd raised at one of the committee meetings, and I see the response there in terms of the CARES Fund, which isn't being continued, but the Minister has said he will work with Community Foundation in terms of the organisations and the programmes that will not be benefiting from that going forward. In relation to the Sure Start piece, I suppose just for the record, I know the Department of Education have come back to me on that one as well, and we've been doing some work locally with the Trust in terms of the early years programmes that have had to end. So thank you to members for allowing me to raise that at that meeting. We also have correspondence from the National Autistic Society and the Children's Law Centre requesting to brief the committee, and we have correspondence from the Community for Behaviour Analysis, who are also asking to meet with the committee, all of which is in relation to the Spotlight programme last week, I'm Not Okay. So I suppose if we're content to consider this as part of our forward work programme, and we can maybe look at some suggestions on how we do it, because we have a number of requests on the same issue. So are we happy to consider that?
Yes.
Yeah, and we can agree what the process is in terms of that.
Chair, if you don't mind, I'd be keen if we could meet with MenCap at the informal
As well,
meeting.
yeah. Sorry, I should have said that there was a request come in directly to myself and yourself around that. So that too will be part of that focus on that documentary. So we can maybe look at what the best way of doing that, because we have a number of organisations obviously involved. Members, we also have a departmental response in relation to hospital car parking charges by trusts at page 8 of your table pack. Have members any comments in relation to that? No. And we also have a departmental response at page 17 of your table papers answering the follow-up questions from the committee after our briefing on ADHD services. Have members any comments in relation to the response? No. Members, we also received an invitation from the Irish Football Association, page 27 of your table papers, inviting the committee to the relaunch of the Irish Football Association Foundation mental health programme ahead of the game on Thursday the 10th of October at the National Football Stadium at Windsor Park. I'm conscious that will clash with
I'll be quick.
with the Oireachtas
Off the train and
visit, yes. So I know some members maybe aren't going to Oireachtas committee meetings, so if it's open to all committee members, so if people can respond directly to IFA on that one.
You get to watch the game, or are they throwing us out after the...
You're playing?
I'm playing?
And members, we also have received correspondence in their table papers from the Royal College of Nursing regarding their concerns on the current reshape and refresh management of change process within the Public Health Agency. Does anyone have anything they wish to raise in relation to that? No. Okay, I think there may be something within it to follow up at a later stage. I just had seen it this morning as well. So, members, a copy of a written statement from the Finance Minister and the Budget Sustainability Plan was also emailed to members this afternoon. If I could ask the clerk maybe just to speak in terms of the information received.
Thanks, Chair. This is just a copy of the written ministerial statement from the Minister of Finance in relation to the Budget Sustainability Plan. So it talks a wee bit there about revenue raising and other issues. So it's all there for members' information. The Committee for Finance will be doing a wee bit of work on that as well. So it's just to keep members informed on that.
Okay, thank you, Keith. Okay, members, are you content with the suggested actions for the remaining items on the correspondence list? Yeah. Item number 12 then is the forward work programme, and it's at page 522 of your pack. We have a very packed couple of weeks coming up, both in and out of committee. The committee's motion, as we've talked about earlier, on Children's Social Care Services is scheduled for Tuesday, this Tuesday coming the 8th of October. Members have also been invited to the Department's Bengoa Conference, which is on Wednesday the 9th of October. And if I could ask the clerk just to take us through some of the visits and the events that are also coming up.
Thanks, Chair. And sorry, just to come back to Alan's point around the Naloxone, there is a mandatory, the training's made mandatory in the legislation. So it is. So the storage and supply of it, there have to be mandatory training with it. So we knew it was somewhere, just couldn't get to it in time, so we couldn't. In relation to the forward work programme, as members will be aware, next Thursday, committee's travelling to Dublin to meet with a Oireachtas Joint Committee on Health, and also to go to St James's Hospital. So there will also be the opportunity to do a tour of the new children's hospital that's still being built. So it will be hard hats and work boots, the high vis. Next Thursday as well, so I will get the final itinerary out to members tomorrow on that, with all the travel arrangements as well. The other thing to flag up is the following week is the NICON conference. So it's a 2-day conference, and I will send out the agenda for that. It's public at the minute. It's a very, very good programme, and members will have access to both days of that. I know the minister's going on the first day, the Wednesday, and then he's obviously come to our committee meeting on the Thursday as well. It's there. Specifically, the committee's involved in 2 very specific areas. On the Wednesday at lunchtime, there's a meet the committee session, which is a chance for people to come and ask questions of the Health Committee. So there'll be a very short presentation around the role of the committee, around its priorities, and then it's really a chance to engage with the people that are there. So it would be great to have as many members at that as possible. So that's on the Wednesday lunchtime.
Where's the venue?
It's Le Mans Hotel.
What time when you say lunchtime, Keith?
I think it's 12:40 to 1:40. So it is. Lunch takes place, I think, between 12 and 2. So it is, and they do sort of lunchtime sessions. So at the same time we're doing ours, there's maybe 3 or 4 other sessions in other rooms going on as well. And then our committee meeting will be held at the site on Thursday afternoon. As it's an external committee meeting, there is no opportunity to join remotely. We don't have the facilities for that yet. The other thing to mention is that day it will be the first time that we will be trying to stream an external committee meeting by video live.
No pressure.
So it is. So on one hand, it's great that we've got an opportunity to do it. There'll be a lot of interest because the minister's coming to brief the committee. We've got the chair of the NHS UK Confederation coming to brief the committee as well. So there'll be a lot of interest. So it's great that we're going to have a chance to try and stream it. But it's just again to make members aware that not everything goes according to the plan. But there definitely won't be an opportunity to join remotely. It has to be in person for now. That could well be something further down the line, but again, it was just to flag that up. The committee will also have an information stand at the event as well over the 2 days, where people who attend the event can come and find a bit more out about the committee and what it does, and can register to come and attend the committee meeting on the Thursday.
I'm sure Jonathan will be able to handle that okay.
And the other thing, just to mention, members had requested an informal session with officials on waiting list statistics and how they're gathered, how they're made up. So we have scheduled that for Tuesday the 22nd of October, and we'll get an invite out for that. It'll be lunchtime on Tuesday the 22nd. And as the chair said, it's a very busy couple of weeks, but a good opportunity for members to meet a lot of new and different people.
Thank you, Keith. And I mean, just again to thank yourself and all the staff for the work that's gone into organising all of these different events. I mean, as I said, we had NIAS this morning. There's been a lot of work outside and over and above the committee work, so it is very much appreciated and it's very, very valuable. So just to put that on record as well. Members, are you content then to note the briefings as set out there for the forward work programme? Thank you. Has anyone any other business they wish to raise? No? Okay, so just obviously we've no committee meeting then next Thursday as we're in the Oireachtas, and the date, time and place for our next meeting is Thursday the 17th of October at 2:15 at the Nikon Conference in Le Mans Hotel. Thank you.
Committee Room 29, Sound. 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 Committee Room 29, Sound.